CVD.
Okay, ma'am. Just sharing my screen. Give me a second. Okay. Okay. So good evening, all the respected faculty members and delegates present all over here. So on the behalf of Corona Remedies, I, Darshan Waghela, welcome you all for this Foxy Icog CME on 7H in association with Maharashtra societies like Nagpur, Chandrapur, Yavatmal, Bhandara, Gondia, and Buldana. So welcome all of you for this platform of Core Connect live webinar. On behalf of Corona team, I would like to introduce now our convener, Dr. Sneha Bhuyer, a state coordinator for AMOGS and National ISOPARP chairperson and quiz committee of 26-28. Our coordinators, Dr. Vaidehi Marathe, Director of Maher Maternity and Nursing Homes, Nagpur, practicing since 28 years, and Dr. Pranjal Sarma, Director of Sarma Hospital, Amravati. Now, for further moving to this entire session, this entire webinar, I would like to hand over the session to our convener, Dr. Sneha Bhuyer. So, respected ma'am, over to you, Sneha ma'am.
Yes. Very good evening to all of you. At the outset, I would like to welcome respected Madam Dr. Sheila Mane, the Chairperson of ICOG, Dr. Pratik Tambe, Secretary ICOG, of course, Dr. Bhaskar Pal, President Foxy, Secretary General Dr. Suvarna. So I think both of them are busy in the meeting, so they could not join. But I welcome all the respected faculty, especially Dr. Seema Dande, Dr. Bhakti Gurjar, all the president and secretaries of Nagpur, Chandrapur, Yavatmal, Gondia, Bandara. I would not waste much time in naming everybody, but without much ado, I would just like to welcome everybody and welcome for the inauguration. Darshan, can we have the inauguration video first? Then I invite the ICOG chair for her address. Over to you, Darshan, for the Yes. So once again, I welcome all of you, and with my coordinators, Dr. Vaidehi and Pranjal, we all of us welcome all of you. And without much ado, I invite Madam Sheila Mane, the chairperson of ICOG, a very cheerful personality, very academic, and of course, very capable leader. So over to you, madam, for your address. Of course, everybody knows madam because madam belongs to our region and she is the ICOG chairperson. She was a member of Health Systems Strengthening Committee of FIGO. She was the vice president of Foxy 2014 and she was the chairperson of Safe Motherhood Committee. I'm sure everybody knows that she was a president of Bangalore Obsgyne Society and she's known as a PPH lady.
Yeah,
So
okay.
over to you, madam.
Thank you. Thank you, Sneha. And thank you, Sneha, for coming forward to conduct this 7H CME. So as I said, that I wanted to do it in every state, and Maharashtra is a very big state. So I told Sneha to take the lead, and first we selected Vidarbha. So I thought it is good to start with Vidarbha. Huh? Apla Vidarbha, I can say. And I'm really happy that all the societies of Vidarbha have joined and come together. So it's so nice to see. Thank you, Vaidehi and Pranjal, for coordinating the whole program. And I think uh, Dr. Seema is there going to speak again, and Dr. Bhakti, who are the speakers. And I think then Dr. Sneha is going to conduct the panel. So all of us are here today. I will be there as an expert, and I know it will be a excellent. Now, why I thought of these 7H's? The 7H includes hemorrhage, hypertension, hyperglycemia, hemoglobin, that is anemia, HIV/AIDS, hormones, and high BMI. So I have prepared a module for all this, and I give the topics and the session. I mean, the region-wise people select which 3H they want to take. And I thought that these are the very important topics, because still we need to concentrate on this, as we see that there is a rise in the incidence of high risk pregnancy like hypertension. Now, PPH is no more a leading cause in most of the states. It is the hypertension, hyperglycemia. I think incidence of diabetes today, if we take into consideration, is almost 20% in urban in our antenatal crowd. So, I mean, these two are really very important, because and I'm also planning to come up with a study on FIGO pregnancy passport. Now, this FIGO pregnancy passport is whosoever has a high risk pregnancy, we continue their follow up like every 6 weeks, 3 months, 6 months, 12 months, like that. Because we know that if they have any morbidity during pregnancy, they will develop these problems in later life. So they have to be under our observation. Because after the reproductive life, again, the perimenopausal, menopausal, they can develop hypertension, diabetes. So that is my another initiative. So I will come back to you, all of you, for that also. So all of us can create a robust data, on this, and that will be one of the publication in ICOG. So that is my another initiative. So I thank everybody. I can see Dr. Lanjevar, Kambale, Dr. Alka participating, as well as Dr. Swati, Dr. Kalpana, and Dr. Ganesh, and also the panelist. And first of all, first most is welcome Dr. Manjula Madam, who has accepted our invitation to be there. Okay. So thank you one and all. And I'm
Thank you.
also waiting to
I'm very much
listen
here.
to all.
Thank you very much. I'm, I'm just trying to get adjusted to everybody. I was looking at everybody's face. I think that your program is going to be excellent in every way. I'm just waiting to hear.
Yes. So thank you so much, Madam Sheila Mane. With God Almighty's blessings, we have already inaugurated the program, and with Madam's chairperson's address, we would like to go ahead with the precious words from our Secretary ICOG, Dr. Pratik Tambe, whom all of you know as a very, very focused academician. And of course, it's very difficult to read your CV, Dr. Pratik. But yes, in fact, we would like to listen to your precious words. So over to you for your address, Dr. Pratik.
Thank you very much, Dr. Sneha Goyal. My hearty congratulations to Dr. Sheila Mani, ICOG, and of course, all the Vidarbha societies for collaborating together in this beautiful 7th CME. This entire series is a brainchild of our esteemed chairperson, Dr. Sheila Mane, and this aims to take the entire knowledge regarding these core concepts of 7 different disorders to every small town, city, and small societies throughout the country. I think this is going to be a landmark series in the history of ICOG. Thank you very much, ma'am, for initiating this. Thank you, Dr. Sneha Boyer, and the other coordinators. I had the pleasure of meeting Dr. Vaidehi Marathe and Dr. Manjula Rocky recently in Nagpur when I was there a few days ago. And I also had the pleasure of meeting the other coordinator, Dr. Pranjal Sharma, in Amravati a couple of months back. So congratulations to all of you. Please proceed and let's not stand on for this.
Yes. Thank you so much, Dr. Pratik. And in fact, thank you so much for your gracious presence. So, I just thank all the president and secretaries. Once again, I welcome those who have joined late. And now I hand over the mic to Dr. Vaidehi to introduce our guest of honor straightway, because our chief guest, Dr. Bhaskar Pal, as I have already said, that he is busy in another meeting and he will not be able to join. So over to you, Dr. Vaidehi. Vaidehi, you need to unmute.
Yeah, sorry. Thank you so much, Dr. Sneha ma'am, for giving us this opportunity to be the coordinators. Thank you, Sheila Mane ma'am. Thank you so much for starting this very useful seminar for all of us. I have the privilege of introducing the first guest of honor. Can I have a CV, please, Mr. Darshan? Yeah. So I think all of us know in Nagpur, Dr. Manjula Rohadgi ma'am really does not need any introduction. She is very highly educated and has held many prestigious positions. Octogenarian in age, but truly ageless in spirit. Her energy, curiosity, and passion for learning continues to inspire all of us even now. A living example that dedication to medicine definitely does not ever retire. Welcome, Dr. Manjula ma'am.
Thank you very much. Thank you for introducing me in a very big way. I don't think I could deserve that, but I'm proud to be here on the stage to give a little bit introduction to the guest of honor and what is my duty as such. So can I start now?
Yes, madam. Yes, please go.
I will say the distinguished guest, President of Foxy Organizer, fellow participant, and very warm welcome to you. Good evening. I'm deeply privileged to join you today as a guest of honor. I'm deeply privileged. First, I must express my heartfelt thanks to Dr. Sheila Mane, organizing chairman of Foxy ICOG, for this kind invitation. It is a pleasure to support initiative that brings together so many bright minds to explore through the webinar. The theme of today's webinar is tackling hypoglycemia in pregnancy and hypertensive disorders in pregnancy. In today's digital landscape, the ability to correct cross-border through platform like this is invaluable. The topics are discussing today is not only timely, but critical for our growth in industry and field economic. I'm eager to share some of my own reflections later in the session, and more importantly, to learn from the question and perspective you all bring to the table. Thank you for your time, your participation, for the honor of presiding over this opening. Let's make this momentous and memorable session. Thank you very much.
Yeah. Thank you so much, madam, for your blessings. And of course, keep blessing us and inspiring us. I'm sure we are truly blessed to have such an experienced and ageless beauty with us today. So thank you so much once again. So actually, Dr. Balchandra Thackeray, I think because of his ill health, is not able to join, though he was supposed to join. So I just in short introduce him, though he has not joined, that he's the senior most obstetrician gynecologist from the city of Yavatmal, and he was the second president of YOGS, that is Yavatmal Obs-Gynae Society. He did practice for more than 40 years, and he was a past president of IMA Yavatmal as well. So, I mean, lots of accolades to his credit as well, and he is an inspiration and guide to all of us. But unfortunately, he could not.
I must add, Dr. Surekha, he was my teacher. I mean, he was a lecturer and assistant professor, and in the same unit under Madam Gohi. So I had an opportunity to work with him during my residency as well as my postgraduate.
Yes, thank you so much, madam. In fact, I did remember that you had shared this with us, and that's a very reason we tried to, make efforts to join him, but unfortunately he could not. So let us now declare that the inauguration is over, and let me thank ICOG chairperson, of course, Madam Sheila Mane, Dr. Pratik, Dr. Bhaskar Pal as the chief guest, though he could not join, and the guest of honor, Dr. Manjula Madam and Dr. B.S. Thackeray. I thank all the president and secretaries, Dr. Sangeeta Tajpuria and Dr. Meghna Agrawal from Nagpur, Dr. Kalpana Gurwade and Dr. Rucha from Chandrapur, and Dr. Swati Motewar and Dr. Kiran Durvevatti from Yavatmal, Dr. Bharat Lanjewar and Dr. Manoj Aglave from Bandara, and of course Gondia, though the president is not able to join, I just say Dr. Ritu Jain, and of course Dr. Garima Bagga and all these people. So I thank all of you once again, and let us now move ahead with the academic session. I thank everyone once again. Now I hand over the session to our coordinators, Dr. Vaidehi Marathe and Dr. Pranjal Sharma. So over to you, both of you. Thank you so much.
Thank you so much, Dr. Sneha ma'am. Let's begin our scientific session. And the session 1 is going to be on tackling hyperglycemia in pregnancy. And Dr. Seema Dande is going to deliver this talk. For this session, it's my real honor and privilege to welcome and introduce today's chairpersons, Dr. Swati Moteva, Dr. Kalpana Gulwade, and Dr. Ganesh Rathod. May I have the series, please?
Yes, myself, Dr. Swati Moteva. It's my privilege to introduce Dr. Seema Dande, ma'am. She is executive.
Swati, you can give
Yes,
her
ma'am.
comment. Dr. Vaidehi has a pleasure to introduce you.
Yes,
Okay?
yes.
Yeah.
Okay, ma'am.
So,
Yeah.
Dr. Swati, yes. Darshan, the previous slides, please.
Yeah. So welcome, Dr. Swati ma'am. It's absolutely our honor to have you today with us as a chairperson. She is a consulting obstetrician and infertility specialist at Arogyam Specialty Hospital, Yavatmal, currently heading the Yavatmal OBGYN Society. Next slide, please. The next chairperson CV, please. Yeah. And Dr. Kalpana Gulwade, a very active member of Chandrapur OBGYN Society as well as at state and Foxy level. She is currently the president of Chandrapur OBGYN Society. She's been the organizing secretary of AMOX Chandrapur held in 2025. And she's held many positions in IMA, Foxy, and as well as in AMOX. Welcome, Dr. Kalpana. Can I have the next slide, please? Welcome, Dr. GB Rathod, who is currently the president of Buldhana OBGYN Society. He's a practicing obstetrician, sonologist, and endoscopic surgeon for the last 25 years. He's been the past IMA president as well, currently the president of OBGYN Society, Buldhana. Welcome, Dr. Rathod. So I hand over the proceedings of this session to the chairpersons. Over to you, chairpersons.
Myself, Dr. Swati Moteva. It's my privilege to introduce Dr. Seema Dande, ma'am. She is executive member of NGS.
लॉगिन करके क्यों रुकना
Just everyone to please keep themselves muted, please. Yeah, Dr. Swati, please unmute yourself and then speak. Dr. Swati, please unmute yourself. Dr.
Swati, unmute.
Yes, ma'am.
Darshan, you can make me or Dr. Vaidehi co-host so that we can, handle.
Yes, ma'am. I will make you co-host.
It's my privilege, ma'am, to introduce Dr. Seema Dande, ma'am. She is executive member of NOGS and faculty at Shalini Tai Meghe Hospital. She is joint secretary of Osteoporosis Society of India. She has many publications and paper presentations to her credit. She is having YouTube channel of short videos on Obstetric and Gynec Society for young practitioners, gynecologists. She has organized workshop in urogynecology at Dande Hospital at Narchikon. She has done diploma in cosmetic gynecology and minimal SS surgery. She is recipient award of Women's Achiever Award in IMS 2018. She also participated in various marathons also. She will enlighten us on hyperglycemia in pregnancy. Over to you, ma'am. Thank you.
Hello, thank you for the kind introduction. First of all, I would like to thank Sheila ma'am, Sneha ma'am for giving me this opportunity. And this is really a very interesting concept of 7H and it's going to be very successful, definitely. Regarding hyperglycemia, I want to tell just 2 points that I want Darshan to share the slides, please. First, I would like to say that being Asians, we are already at high risk because of our ethnicity. And so nowadays in our practice, we are going to see and we are seeing a lot of ANC patients who are already having diabetes. Secondly, as obstetricians, we have a double responsibility because we are treating the women from adolescence during pregnancy. And if we manage to control the diabetes, we are managing the next generation also. Because if a child is born to a woman with type 1 diabetes, there is a 3 to 5% chance that the child will have diabetes in future, the same type of diabetes. And if the woman is having type 2 diabetes, then the child will have 15% chance in future of developing diabetes. If the mother is having gestational diabetes, then the child has a risk of having obesity and diabetes in his when he becomes adult. So we have a dual responsibility, like we are managing both the generations. So this, I will divide it into preconception, antenatal care, intrapartum care, postpartum care, and neonatal care. Next. So in the preconception period, Darshan, next please. In the preconception care, we have to educate the women that good blood glucose control is essential to manage 4 things, because it will reduce the risk of miscarriage, second, congenital malformations, stillbirth, and neonatal death. It will the risk is reduced, but it is not completely eliminated. That we have to keep in mind. Secondly, it should begin in adolescence itself. Next slide. So we have to tell them about the role of diet, body weight, and exercise. At the same time, we have to educate them about the risk of hypoglycemia and how to be aware of the hypoglycemic symptoms, which is more so in early pregnancy because nausea, vomiting will affect the blood glucose control. And we should educate them of increased risk of baby who will be large for gestational age, which will ultimately lead to birth trauma, induction of labor, instrumental birth, and cesarean birth. Apart from this, there are 2 main conditions, that is, we have to screen them for diabetic retinopathy and nephropathy, as well as I have discussed earlier, that the baby can have a high risk of obesity, diabetes, and other health problems in later life. Next. So we have to emphasize this importance from adolescents and advise them that they should use a good contraception before they embark on pregnancy. And if they are having type 1 diabetes, still they can use the oral contraceptive pills. Next. So this is an important point, that the risk associated with diabetes will increase the longer duration they are having diabetes, and they are asked to use the contraception and good blood glucose control and tight glucose monitoring, and the review of medication should be done once they embark on pregnancy. Next. And we have to offer them individualized dietary care, and we have to refer it to the dietitian. And the most important thing here is that the BMI. So if the woman is having a BMI of 27, then we have to ask her to reduce weight before they are planning pregnancy. Second is folic acid. The dose is 5 milligrams per day, which has to be given until 12 weeks of gestation to reduce the risk of having a neural tube defect. Third, next slide. They should be asked to do a monthly measurement of HbA1c level and blood glucose meters for self-monitoring. We have to intensify the blood glucose lowering therapy and advise her to monitor her blood glucose to include fasting levels and a mixture of pre-meal and post-meal levels. Those who are having type 1 diabetes, they should be given blood ketones measuring strips, because there is a high risk of developing diabetic ketoacidosis. So if at all they feel hyperglycemic or unwell, they should do the blood ketone test measurements. Next. So what are the targets? Like if a woman with type 1 diabetes is planning for pregnancy, then how much her normal capillary plasma glucose should be there? So the target should be a fasting plasma glucose of 5 to 7 millimoles per liter on waking up, or a plasma glucose of 4 to 7 millimoles per liter before meals at any other time of the day. So in this, I have written millimoles per liter, and to convert it into milligrams per deciliter that we follow in our day-to-day practice, we have to multiply it by 18. So it comes to around 95 to 126. So the fasting should be 95 to 126 and 4 to, and it should never be below 4 millimoles because it indicates hypoglycemia. Advise women with diabetes who are planning to aim to keep the HbA1c level below 6.5, because if this is the target which you have to maintain, if this is achievable without causing problematic hypoglycemia. We should reassure that any reduction in the HbA1c level towards the target is likely to reduce the risk of congenital malformations in the baby. Now, if the HbA1c is 10%, that is 86 millimoles, then you should advise against pregnancy. So this is a contraindication. If the HbA1c is 10%, then she is not allowed to conceive. Next. So when she wants to be pregnant, so we have to see the safety of medications also. So if she is having pre-existing diabetes and she is on metformin, then it can be used as an adjunct therapy or an alternative therapy to insulin in the preconception period as well as in the post-conception period. She can use glibenclamide, but no other glucose lowering agents are allowed. So metformin and glibenclamide is the only thing. Apart from the oral hypoglycemic agents, she can use the insulin analogs. So the short-acting insulins, that is the Lispro and Aspart, they are safe to use in pregnancy. Second is the isophane insulin, that is the NPH insulin, which is this is a insulin which will bring about the slow and steady control of the blood sugar levels. So that is also recommended. Of course, we have to manage the woman with a joint diabetic clinic once she gets pregnant. But this is a preconception we are discussing. Then the second is the insulin glargine, which is also a long-acting insulin analog. It is also useful for women with diabetes who have established good blood glucose control before pregnancy. According to the NICE guidelines, now it is recommended that the Levemir or the Tetemir insulin, they are going to stop it after December 2026. So this is a recent update in the NICE guidelines. Next. Apart from the oral hypoglycemic agents, if she is on other medicines like the angiotensin converting enzyme inhibitors or the ARB blockers, they should be stopped as soon as they should be stopped before conception or as soon as the pregnancy is confirmed, because these drugs are renoprotective and they are used if she is already diabetic and having albuminuria, but they should be stopped. Secondly, the cardioprotective medications like the statins also should be stopped once the pregnancy is confirmed. Next slide. Retinal assessment for women with diabetes. So they should undergo a retinal assessment if it is not done in the last 6 months, and if it is diagnosed and treated. Till then, we should defer rapid optimization of blood glucose, because the blood vessels which are used for the hyperglycemic condition, if we rapidly control the blood sugars, it will lead to activation. They are like crying for blood sugar. So there will be activation of the vascular endothelial growth factors, which will lead to proliferation of blood vessels, which will be leaky blood vessels, and it will lead to aggravation of the diabetic retinopathy. So rapid optimization of blood glucose should not be done until they have retinal assessment and treatment. Next. Then we have to do the renal assessment before they embark on pregnancy. And if the serum creatinine is 120 micromole per liter, which is around 1.36 milligrams per deciliter, if the urine albumin creatinine ratio is 30 milligrams per millimole, and the GFR is less than 45, these patients should be referred to nephrologist. And if this is there, then she is advised to use good contraception. Next. Now, coming to gestational diabetes, we all know that this develops during pregnancy, around 24 to 26 weeks of gestation. So most of the women, they can be managed by diet and exercise, but some women need the oral glucose lowering agents or insulin. And we all know that if it is not taken care of, then the most dreaded complication is shoulder dystocia. These women will need more monitoring, more interventions during pregnancy and labor. So during our in the OPD, whenever a woman comes, so we have to think of these 5 pointers like BMI of 30, previous macrosomic baby, previous gestational diabetes, family history of diabetes, and ethnicity. So even if one of them is there, then we have to do the screening test for diabetes. So as we belong to the Asian ethnicity, we do it for every woman, but it is not so in other parts of the in other countries. So in India, we are doing the glucose tolerance test for everyone. So we should not use fasting glucose, random glucose, HbA1c, glucose challenge test, or urine analysis to know the risk of developing gestational diabetes. Next. During routine checkup, if the woman is having glycosuria of 2+ or above on one occasion, or 1+ or above on 2 or more occasion, then you should think that she might be having pre-existing diabetes. So what do we do if these risk factors are present, or if glycosuria is present? We have to do the 2-hour 75-gram glucose tolerance test at 24 to 28 weeks of gestation for gestational diabetes in women with risk factors. So in all the conditions, we will do it at 24 to 28 weeks, except one condition. Next slide. Except one condition where the woman is having gestational diabetes in the previous pregnancy. So if there is gestational diabetes in previous pregnancy, we will do it in the first trimester itself or at the time of booking, that is at 16 to 20 weeks. And if it is normal, then still we again do it at 24 to 28 weeks of gestation. Next. Now we did the test. Now, how are we going to diagnose? So the fasting plasma glucose of 5.6 millimoles per liter or above, or a 2-hour plasma glucose level of 7.8 millimoles per liter. So it is easy to remember 5, 6, 7, 8. And there is a or in between. So it is not necessary that both the things should be there. So if only the fasting level is 5.6, which comes to around 100 milligrams per deciliter, and 7.8 comes to around 140. So even if one value is abnormal, we can diagnose it as gestational diabetes. Next. Next, please. So if we have diagnosed it, then we should refer her to the dietitian. We should advise her to have a walk for 30 minutes after a meal. And now we are going to manage. So how are we going to manage? Depending on the plasma glucose levels. So if the level is below 7 millimoles per liter, we will give a trial of diet and exercise and give 2 weeks to her. If it is not met, then we will offer metformin. If metformin is contraindicated or unacceptable, then we will offer insulin. Next. So if there is gestational diabetes and fasting blood glucose of 7 millimoles or above, then immediate treatment with insulin with or without metformin. Diet and exercise will follow in every case. And women with the fasting plasma glucose of 6 to 6.9 plus complications like macrosomia or hydramnios, then also we will consider immediate treatment with insulin. With or without metformin, diet and exercise will follow. So this is a diet chart which tells that the protein intake should not be more than 1 gram per kg. The fat should be less than 35. And they have focused that the PUFA, the N6 polyunsaturated fat, it should be less than 10%. The diet should contain fish, and the cis monounsaturated fat, that is the MUFA, it should be 10 to 20%, and it is available in olive oil, in pumpkin seeds, in the sesame seeds, in the peanuts and almonds. And the salt should be less, vitamins and antioxidants. Next. So in antenatal care, it's a joint care by a diabetologist, obstetrician, neonatologist, dietitian, and the nephrologist and the ophthalmic surgeon. So all will take care of the women. Every 2 weeks follow-up is needed. Those women who are having type 1 diabetes, they will do their fasting pre-meal. 1 hour post meal, and bedtime glucose levels daily. Those women with type 2 diabetes who are on multiple daily insulin injections will also follow the same protocol. That is fasting, pre-meal, 1 hour post-meal, and bedtime. But women with type 2 diabetes or gestational diabetes, they will just do their fasting and 1 hour post-meal blood glucose levels daily if they are managing their diabetes with diet and exercise, or taking oral therapy or single dose intermediate acting. So they don't have to do the intensive monitoring like type 1 and type 2 with multiple daily insulin injections. Next. So we are treating her. So what are our targets? That how much should be the capillary plasma glucose levels? So the fasting should be 5.3, 1 hour 7.8, and 2 hours 6.4. So in our values, it will come to around 95 and 115. So fasting should be always 95 and less, and 2 hours should be 115. So, and it should never go below 72 milligrams per deciliter, which is hypoglycemia. Next. So we have to give measure HbA1c for women who are having pre-existing diabetes to determine the level of risk for this pregnancy, and we can offer it in the second and third trimester. And in women who are having gestational diabetes, in them we have to do HbA1c just once to see whether it is really a gestational diabetic or she is already having a pre-existing diabetic. So for gestational diabetes, HbA1c measurement is recommended once only. And obviously, we have discussed that it should be never above 6.5%. Next. Skip this slide. This is double F. Skip this one also. So how are we going to manage diabetes? So we have discussed that there are rapid acting insulin analogs like Aspart and Lispro, and they should be told about the risk of hypoglycemia. They should be given a fast acting form of glucose available like glucose tablets or glucose containing drinks. And type 1 women should be given glucagon, and they should come to us immediately if they feel unwell or hyperglycemic. And we can offer the continuous subcutaneous insulin infusion to pregnant women who are using multiple daily injections and still they are not able to manage the blood glucose levels because of disabling hypoglycemia. Next. These are the two new things, that is a real-time continuous glucose monitoring. It can be given to type 1 women who are not able to meet their blood glucose targets and they are having hypoglycemia. Similar is the flash, that is the intermittently scanned continuous glucose monitoring. This can also be given to them to avoid problematic severe hypoglycemia. Next. Now we have discussed that ketone strip should be given to these women because they should come immediately if they feel hyperglycemic or unwell. This applies to type 2 as well. Next. Retinal assessment we have done in the preconception, but if she lands up in pregnancy, then what we do? We have to do the retinal assessment, and if it is normal, then we will do it at 28 weeks again. But if it is abnormal, then we will do it at 16 to 20 weeks again to see there is aggravation of proliferative retinopathy or not. And yeah, next. Similar to the renal assessment, serum creatinine, albumin creatinine ratio that I have discussed in the preconception, we do it again. But the GFR should not be used because it changes in pregnancy. And instead, we have to measure the total protein excretion if it is more than 0.5 grams per day. And if it is more than 5 grams per day, then we have to give the thromboprophylaxis to her because it's a high risk for venous thromboembolism. Next. Then regarding the management of baby, we have to do the ultrasound to see the all the chambers for any structural cardiac abnormalities, as well as the fetal growth assessment from 28 to 36 weeks. So these are the methods. This is all we have discussed in this chart already. Next slide. So we can carry the pregnancy who is gestational diabetes till 40 weeks of gestation. But the insulin dependent diabetes, we can carry the pregnancy till 37 to 38 weeks of gestation, and still early if she is having macrosomia, hydramnios, or any other complications. Next. So what to do in preterm labor women? So diabetes should not be considered a contraindication to tocolysis, but if they are on treatment with insulin, then we are giving steroids, then naturally the sugars are going to rise. So we have to give additional insulin according to the agreed protocol, but you should not use beta mimetic medications for tocolysis in women with diabetes because it aggravates the blood sugars. Next. Regarding intrapartum care, so type 1, type 2 diabetes, no other complications. They can be delivered by induced labor or cesarean section between 37 to 38 weeks, and elective birth at 37 if there are maternal fetal complications. Those with gestational diabetes, 40 weeks plus 6 days by induction of labor or cesarean section. Elective birth before 40 weeks if they have maternal or fetal complications, but they should be told about the risk of shoulder dystocia. And for pregnant women with diabetes who have an ultrasound diagnosed microscopy, explain the risks and benefits of vaginal birth, induction of labor, and cesarean section. Next. So anesthetic assessment should be done in the 3rd trimester itself, and generally we do the regional anesthesia, but if general anesthesia is given, then monitor blood glucose every 30 minutes from induction of GA till the baby is born. Next. Blood glucose during labor, the capillary level should be maintained between 4 millimoles to 7 millimoles per liter, and intravenous dextrose insulin infusion should be started from the onset of established labor with type 1 diabetes. Use intravenous dextrose and insulin infusion during labor with diabetes whose glucose is not maintained between 4 to 7 millimoles per liter. Next. So neonatal care, we have to observe the baby for 24 hours, and babies of women with diabetes should stay with their mothers unless there are complications or any abnormal signs. And the blood glucose testing should be done at 2 to 4 hours after birth in babies. And we have to screen for 4 things, that is polycythemia, hyperbilirubinemia. These 2 things are rising and 2 things are falling, that is hypocalcemia and hypomagnesemia. And if there is you feel that there is a murmur or breathing difficulty, then we have to do the echocardiogram. Next. So admit the babies with diabetes to NICU if they have all these symptoms like hypoglycemia, respiratory distress, cardiac decompensation, neonatal encephalopathy, polycythemia, need for tube feeding, if there is jaundice, or if they are born before 34 weeks of gestation. Next. So do not transfer the babies to community care until they are at least 24 hours old and you are satisfied that the baby is maintaining good blood glucose levels. The baby will not effectively feed orally. For babies with clinical signs of hypoglycemia, test the blood glucose and provide IV dextrose as soon as possible. Next. So they should feed the baby within 30 minutes at frequent intervals, and the blood glucose should be 2 millimoles per liter. And we can use tube feeding or IV dextrose if the plasma glucose of the baby is 2 millimoles on 2 consecutive readings despite maximal support for feeding, or if there are abnormal signs, or the baby will is not getting feeds properly orally. Next. Postnatal care, the women with insulin type 1 diabetes, they should reduce their insulin immediately after birth and monitor their blood glucose level to find the appropriate dose. Explain to the women with insulin treated pre-existing diabetes that there are increased risk of hypoglycemia in the postnatal period, and they should have a snack or meal immediately because during breastfeeding they are likely to have hypoglycemia. Those women who were gestational diabetes should stop blood glucose lowering therapy immediately after birth. Women with pre-existing diabetes, they can resume or continue metformin therapy immediately after birth, but should avoid other blood glucose lowering therapy. Next. And other medications which were stopped previously that can be started. Okay, next. So we have to advise lifestyle advice, and we have to offer a fasting plasma glucose test at 6 weeks follow up. And at 6 weeks, next slide. At 6 weeks follow up, if the plasma glucose level is below 6, it means that there is a low probability of having diabetes, but they should continue to have lifestyle advice, but they should need annual test to check their blood glucose levels as normal. And if the levels if the levels are 6 to 6.9, then there is a high risk. And if it is more than 7, then there is obvious she is diabetic right now. If they miss this 6 weeks follow-up, then we have to do the HbA1c at 13 weeks. Next slide. So how will we classify them? So if the HbA1c at 13 weeks is 5.7%, then they have a low probability of having diabetes at the moment, but they should continue the lifestyle advice. They need annual check to see for the blood glucose, and they have a moderate risk of developing type 2 diabetes. If it is between 5.7 to 6.4, they are at high risk of diabetes. And if it is 6.5%, then they are already diabetic, and we will refer them to further care. Next. So we have to follow up these women and give advice regarding diet, exercise, continue those who are with type 1 diabetes, they will continue in the routine diabetic management. And in the next pregnancy, we have to again follow the same rules, because there is an increased risk of recurrence as we have seen. So this is all about diabetes, pre-existing, gestational, and type 2 diabetes. Thank you so much.
Yeah, so thank you so much, Seema. It was a very pace run you ran through with your on the marathon and diabetes. Just one small question I wanted to ask to you and maybe to the seniors. We were talking about not giving beta sympathomimetics as tocolytics. Your take on tocolytics for a gestational diabetic patient?
Because see, they stimulate the beta receptors, which are responsible for they will, if the beta mimetics are given, they will stimulate the beta cells in the pancreas, and ultimately it is going to cause aggravation of the diabetes. And if we give steroids in combination with the beta mimetics, then it will lead to fluid overload, and there is a risk of pulmonary edema also in these patients. So beta mimetics should not be given because it aggravates hyperglycemia.
So,
So we
ma'am,
have to predict-
madam or somebody can, madam, senior
Yeah,
madams
yeah.
can throw light.
I think it was very comprehensive, very nicely. I think you covered everything. Okay. But I think what we are seeing nowadays, as I told about that FIGO pregnancy passport, like you have to see that they come for follow up, I think. And you stressed upon that also. And another thing is the contraception. I think unless and until we tell them, otherwise, these people, they become again pregnant and then they come for MTP also because their sugars are not controlled. And when we tell them about congenital malformations, even though the risk is some 20-30%, they get scared. So it becomes very difficult to convince them. Okay. And what I am seeing in my practice now is like many are coming with type 2 diabetes. They are already diabetic, and still we are talking about uniform screening, but still it is not happening. And when they come in second or late third trimester, we find that their sugars are high. The thing is because just sometime when RBS is done, RBS will not serve the purpose. We will have to do the DIPSI test. That means we have to do that 75 grams test, and after 2 hours, we check for it. Cutoffs you told for, I think for Indians, we say 95 fasting and 120 postprandial. Accordingly, they have to manage. So otherwise, we will have macrosomias and all those problems. So very well spoken, and congratulations.
Yes, thank you, ma'am. Thank you so much.
And any other comment from the chairpersons? Otherwise, we can go ahead. Yes. So, Dr. Pranjal. Please unmute.
Yeah. So after this excellent academic session, let us march towards the second session, which is management of HDP. Thank you, Sneha madam, for giving me this opportunity. Thank you, Sheila Mane madam. Thank you so much. So it's my privilege to introduce Dr. Rajni Kamble madam. Madam is there?
You can introduce.
Dr. Rajni Kamble madam is a past president of Yavatmal OBGY Society. She is an experienced obstetrician and gynecologist with over 14 years of experience. She is a consultant at Samyak Ortho and Maternity Hospital and a former assistant professor at SVN GMC Yavatmal with 12 years of experience. As I said, she is a past president of YOGS, Yavatmal Obstetric Gynae Society. She is actively involved in academic activities. She has many national awards as well as she has international she has paper presentation at international and national levels and rare case presentation. So this reflects her commitment to continuous learning and excellence in her field. So over to you, Rajni madam, for introducing the chairpersons.
No, you introduce all the three chairpersons, Pranjal.
Okay,
And then
okay madam.
chairperson will introduce.
Can I get the next slide, please? I'm honored to introduce Dr. Bharat Lanjewar sir. He's a consultant at Sahayoga Hospital Test Tube Babies Center in Bhandara. Sir is a president OBGY Society Bhandara. He's practicing since 35 years, founder secretary of Bhandara OBGY Society. His special interests are in managing high-risk pregnancy, infertility patients. He conducts various medical awareness programs, and he is always at forefront whenever it comes for any academic activity. So welcome, sir. Next slide, please. It's indeed an honor to introduce Dr. Alka Kumar madam. She's a practicing gynecologist since 30 years, former assistant professor at RDG Medical College, Ujjain, MP. She has many publications at international journals like International Journal of Menopause, Menopause Live, August 2013. She has contributed chapters to Clinical Guidelines to Menopause 2015. She also contributed chapter to book Menopause, Past, Present and Future, the social aspect of menopause. She has tremendous work on menopause. She also has written a chapter on genital malignancy, practice approach to menopause, member of International Menopause Society, IMA Menopause Society, Nagpur. Narchi Vishakha Committee, Maharashtra. Madam was a president, Narchi 22 to 24, past president of MNS, was vice president NOGS 2009 to 10. She was also past president of NOX 2025 to 26. Madam member of Public Forum Committee, Fogsi 2013 to 16. She had presented paper at international and national conferences. She has many awards and accolades to her credit. Best Free Paper Award at IMS Conference 2018, Bharat Excellence Award, and featured in Asia Pacific Who's Who. She is passionate about spreading awareness and educating women on genital malignancy and breast cancer. Creator of Suno Sahelia, a cervical cancer screening song. So with this all, I welcome you, Dr. Alka Kumar, and I hand over for further proceedings. Next slide, please.
Is Dr. Alka here? She was here actually. Yeah.
Yes.
Yes, Alka, please go ahead.
So, Alka madam, over to you. Please introduce today's speaker, Dr. Bhakti Gurjar.
At the outset, let me thank all the organizers for giving this opportunity. And it's indeed a very excellent 7H which Sheila madam has started. So a very practical approach to enlighten all our OBGYs. So without wasting time, let me introduce Dr. Bhakti Gurjar. Actually, she doesn't need an introduction, but she has worked with me, a very sweet and very beautiful woman. I have an opportunity to work with her. She's associate professor at IGGMC Nagpur, vice president of NARCHI Nagpur chapter 24-26, secretary Nagpur Menopause Society 25-27, and joint treasurer NOX 24-25. She's Fogsi recognized advanced infertility training, and she has 15 national and international publications peer-reviewed of Jogi. She has authored many chapters like Practical Approach to Menopause Management, undergraduate and postgraduate teacher. She is and a life member of IMA, NOGS, IMS, NRG, and MS. Here I would like to add that she has conducted a PPH workshop when I was a president of NRG, and it was excellent. She has done a very good job with that. And thank you very much for this. And over to Bhakti. The floor is yours now.
Thank you so much, ma'am, for your very kind words of introduction. Mr. Darshan, please, can you share slides?
Yes, sure, ma'am. Just give me 1 minute only to download
At
and
the outset, let me thank ICOG, Dr. Sheila Mane, ma'am, Dr. Sneha Bhuyar, ma'am, and Dr. Vaidehi, and the whole team for handing over this responsibility of discussing management of hypertensive disorders of pregnancy. I have been given 18 minutes to complete this. I don't know how I'm going to do it, but I will definitely try. Okay, are the slides visible?
Yes.
Yes, yes.
I'm not able to move slides, Darshan.
If that one is
yes, I will move on behalf
yeah,
of you.
please,
You just
please
say
move the
next.
slide.
I will
Next
move.
slide, please. Okay, so the reason why we are discussing hypertensive disorders of pregnancy is that the global prevalence of hypertensive disorders of pregnancy is still very high. It is at about 9%. Maybe it is a little higher in primigravida and maybe a little lower in multigravida, but it is still high. The incidence of preeclampsia is 0.4% and that of HELP syndrome is 0.3%. So that is a lot. Almost 25%, that is 1/4 of the maternal deaths are because of hypertension in pregnancy. So हम इसके बारे में जितना भी बात करें उतना कम ही है. Next slide, please. At the beginning, let me tell you that I have based this presentation on the latest guidelines on hypertension in pregnancy by ICOG, which were released this year itself in 2026. The earlier guidelines, which came in 2014 and they were updated in 2019, have now been updated in 2026. So most of the guidelines remain the same, but whatever changes are there, that of course you will come to know as we run through this presentation. So classification, as far as classification is concerned, there is not much change here. Hypertension in pregnancy is still defined as a blood pressure of more than 140/90 taken diagnosed by at least 2 readings taken 4 hours apart after 20 weeks of gestation. Gestational hypertension is without proteinuria and without any organ dysfunction and resolving within 6 weeks postpartum, whereas chronic hypertension is the hypertension which occurs before 20 weeks of gestation and it may persist even 6 weeks postpartum or even later. It can be either a primary or essential hypertension, or it may be secondary to some renal or cardiac cause. Superimposed preeclampsia is when a patient who is chronic hypertensive develops preeclampsia on top of it. Next. So now coming to the most important part, that is preeclampsia and eclampsia. The earlier definition of preeclampsia mandated the presence of proteinuria, which is not so. So preeclampsia is either a raised blood pressure of more than 140/90 with proteinuria or presence of organ dysfunction in the form of neurological complication or lung, liver or renal involvement or presence of severe affection of the fetus. And eclampsia, of course, means presence of generalized tonic-clonic seizures in a patient who is already preeclamptic. So all in all, it's a multi-system disorder. Next. So preeclampsia can be without severe features, which was earlier on called as mild preeclampsia, or it can be with severe features. So without severe features is when the blood pressure is between 140/90 to 160/110 without any warning signs and with normal labs, whereas severe features include a blood pressure of higher than 160/110 or BP less than 160 by 110, but with presence of premonitory signs, symptoms, or abnormal lab parameters, which include thrombocytopenia, that is a platelet count of less than 1.5 lakhs, or elevated liver enzymes, that is twice the reference range for that particular lab, elevated serum creatinine more than 1 milligram percent, or abnormal coagulation profile. Now, two special considerations here are white coat hypertension, which means that the patient may have a normal blood pressure at home, but in clinical settings, the blood pressure comes out to be high. The opposite of white coat hypertension is masked hypertension. That is, at home, the blood pressure shows to be high, but when the patient comes to clinic, it turns out to be normal. So these are two special considerations where the patient needs to be closely monitored, because these patients can still become hypertensive at any point of time and have complications. Next. So I'll quickly rush through screening and prediction so that we can spend a little more time on the treatment part. So screening for preeclampsia has to be universal. HDP gestosis score has been devised. We can very proudly say that it's a indigenous score we developed in India, and now it is recognized by the National Health Mission, that is NHM also, and it is being widely used. It is so simple that it can be used by a basic level healthcare worker also. So basically it is to be done at the first antenatal visit itself, and then with every antenatal visit till 32 weeks of gestation, it is to be repeated, so that it's a dynamic score. It's not a fixed or a static score. So if new risk factors go on appearing later, then the score can be changed. But it is to be seen at least once in each trimester. Next. So how do we calculate the score? Each risk factor is assigned points of 1, 2, or 3. The point is given score depending upon its severity and the strength of its association with preeclampsia. And then all the points are to be added to get a cumulative score. If the cumulative score is more than 3, then it means the patient is at risk of having preeclampsia and it needs to be taken note of. Next. So these are the risk factors. Score 1 is given for mild risk factors like age more than 35 and primary gravida score status. Score 2 for moderate risk factors, and score 3 for high risk factors like autoimmune diseases and renal diseases. So if a patient has a single high risk score, she will directly get a score of 3. Or if she has one mild risk factor and one moderate risk factor, she will still have a score of 3, which will put her at high risk of having complications of preeclampsia. Next. So gestosis score is very good for low resource setting, but when resources are available, multimodal screening between 11 to 14 weeks is ideal. And this has to be offered to all patients who come to us. So this multimodal screening risk assessment includes maternal characteristics just like gestosis score. And apart from that, the mean arterial pressure, uterine artery Doppler pulsatility index, and serum placental growth factor. So a combined approach, including all these factors, calculates a risk score for, a risk calculation for the patient, and that can really be a guiding point for us to give her further preventive measures. Similar gestosis score like scores are available in the Western world. NICE and ACOG guidelines, they promote scores like the full Pyers and the PrEP S and PrEP L, which are risk prediction models which are based on regression analysis. So they have these online formats wherein you just have to put in the patient characteristics, and then the system generates a risk percentage for that particular patient. So if the risk is high, then the risk of complications of development of preeclampsia and its complication is high for that particular patient. So they are also very good tools. The clinical purpose of multimodal screening is to identify women who are at high risk of developing preeclampsia, and this should also be integrated into routine antenatal care. Next. So once the risk score is found to be high, the ICOG gives a simple algorithm to take care of this high risk. So if the gestosis score is found to be high, that is 3 or more, then the recommended dose for aspirin is 75 milligrams per day. Whereas if the multimodal screening turns out to be positive, then the recommended dose is 150 milligrams per day. The timing of initiation, it should be as early as possible, as soon as we diagnose the patient to be high risk, ideally before 16 weeks, but as late as 20 weeks, starting it is also going to give some benefit. And the best benefit is obtained if the patient compliance is good. That significantly improves the effectiveness of this preventive measure. And it is also important to tell the patient to take aspirin, preferably at bedtime. How long to continue? It is to be continued till 36 weeks completed weeks of gestation. Next. Now, additional preventive measures which have shown some use is calcium. Calcium in high doses, that is 1.5 to 2 grams per day, has been found to reduce the risk of preeclampsia and hypertensive disorder. The mechanism of action is that it improves vascular stability and regulates blood pressure during pregnancy. Although it may be effective in the lower doses also, but then those studies are not very, the data is not so robust so as to suggest benefit of lower doses. Second, preventive supplement can be vitamin D in doses of 1000 to 2000 international units of oral vitamin D daily. It has been shown to improve placental function, immune regulation, and maternal bone health is also improved by oral vitamin D. So apart from these, many factors have been studied, including vitamin C and antioxidants, but the data does not suggest their preventive role in preeclampsia. Next. Now, in spite of having screening methods and prevention, we still do have patients who land up with hypertension. So what is needed is to have vigilance in our OPDs and have a close look at the maternal alerts, of which we are all aware. If we want to prevent complications like eclampsia, HELP syndrome, placental abruption, preterm birth, and intrauterine fetal death, we must pay attention to these maternal alerts so that timely referral is possible to specialized centers and prompt management can be initiated. Next. 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 So maternal symptoms can be in the form of warning signs, blurring of vision, upper right quadrant pain, sudden weight gain, and so on. Whereas clinical signs, the most important is taking blood pressure, that too in correct way. That is the most telltale sign. Apart from that, noting sudden weight gain 1 to 2 kg per week or more. So we are all aware of clinical signs. It is just that we need to note them very vigilantly. And then biochemistry, the lab parameters which we just discussed, LFT, KFT, rising LDH, rising serum creatinine, these are all the maternal alert signs. Next. Diagnosis rests basically on taking blood pressure. This is the most important clinical test. Accurate measurement requires proper technique and correct cuff size. That is of utmost importance. Blood pressure should be measured with the patient lying in comfortable position, and either of the two arms can be used for measurement. Proteinuria assessment, conventionally we have been using urine dipstick method, and proteinuria of 1+ or more is considered positive, although ACOG says 1+ can be false positive in almost 70% of patients. So they recommend a 2+ or more of urine dipstick positive, but ICOG says 1+ or more should be taken as positive. Then we have other methods like 24-hour urinary collection method showing 300 milligrams or more of proteinuria per day, but we know that it is cumbersome. So the more specific tests are urinary protein to creatinine ratio of more than 30 milligrams per mole in spot urine sample. And even more specific is albumin to creatinine ratio of more than 8 milligram per millimole, and they should be used for diagnosis now. Next. Next. So after doing baseline laboratory test, we need to order additional test especially if platelet count is less than 1.5, then a detailed coagulation profile has to be ordered, and serum electrolytes in severe cases. We all are in a habit of doing obstetric ultrasound with Doppler for fetal growth and placental assessment, but sometimes we may miss doing the upper abdominal scan and looking for liver and kidneys for presence of subcapsular hematoma or hepatomegaly, and for taking a look at kidneys for not missing some renal cause for hypertension. So this also needs to be looked for. Next. 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 Okay. Additional diagnostic tools that are needed, fundoscopy should be done for all patients. It not only helps to differentiate between chronic hypertension showing chronic long-standing changes from the new onset one, but it also detects retinal hemorrhages and papilledema. Now, echocardiography is a very important tool to diagnose left ventricular dysfunction, which can very well be associated with severe type of preeclampsia, and especially in patients who are already at higher cardiovascular risk, it must be done. Neuroimaging is not needed routinely. MRI brain is performed when we are suspecting certain neurological complications like the posterior reversible encephalopathy syndrome, and to differentiate PRES from stroke or cerebral venous thrombosis. Then the new biomarkers that have come as additional diagnostic tools are placental growth factor and SFLT1, that is soluble FMS-like tyrosine kinase 1 to placental growth factor ratio. Next. Next. How to interpret this? So whenever available, it can help us to know the severity of preeclampsia. So placental growth factor, the normal values of which are around 100. If it becomes low, that is lower than 12 picograms per ml, or the ratio is increased. The ratio of SFLT1 to PLGF, normally it is less than 38. If it becomes more than 85, then the patient is at an increased risk of complication. So this need not be done on a regular basis, but initially at the time of diagnosis, this can be done once and then maybe repeated on the basis of the disease severity. But it can be a very good diagnostic tool to know the severity of complications and for prognostication. Next. 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 Okay. The surveillance of the fetus is equally important. Of course, a baseline anatomy scan along with uterine artery Doppler is a must. But if the patient is already hypertensive, if she has chronic hypertension, then a 4-weekly follow-up with a growth scan has to be done every 4 weeks. If the patient has gestational hypertension without any complications, then also the scanning should start at the time of diagnosis and then 4-weekly can be done provided it is normal. But when we have a patient of severe hypertension or preeclampsia, then for such patients, inpatient monitoring is required. And if at all, if we plan to continue the pregnancy in spite of severe preeclampsia, then growth scan is to be repeated 2-weekly. If the fetus is compromised, then depending upon the status of the fetus, it may be repeated even more frequently. Every time amniotic fluid must be assessed, and this has to be combined with a CTG and BPP score. Next. Then coming to the important part, that is control of hypertension. So treatment is recommended whenever the blood pressure is more than 140/90. Isolated systolic hypertension should also be treated, and the target blood pressure is not that magical figure of 120/80 or 110/70. In fact, at such low BPs, uteroplacental circulation may actually be adversely affected. So our target is 135/85 and not very low. The choice of antihypertensive will depend on what are the patient's characteristics, what are the pre-existing comorbidities or clinical condition, and of course, physician preference. Next. Next. So for longest of times, probably methyl dopa was used as the drug of choice for hypertension in a dose of 250 to 500 milligrams. But then maybe for last 10 years or so, now we have labetalol as the first line drug or the drug of choice. We started at 100 to 200 milligrams BD to TDS. The maximum dose is 2.4 grams, that is 2400 milligrams. But when a dose of 1000 to 1200 milligrams per day is required, then it is nice to add a second drug if monotherapy is seen to be not working. Nifedipine is an equally good drug in a dose of 10 to 20 milligrams per day, but it tends to cause hypertension. So preferably it should be used when the pulse rate is less than 100. Next. Next. Other drugs which can be used are amlodipine, nicardipine, metoprolol. They are also safe. But some drugs may cause maternal tachycardia or even adverse fetal effects. Diuretics as such are generally avoided because of the already compromised vascular intravascular volume. They may further reduce the intravascular volume and may seriously compromise the uteroplacental circulation. So they are to be avoided. ACE inhibitors and angiotensin receptor blockers, there is a risk of teratogenicity, so they have to be either stopped before planning pregnancy or at least after UPT becomes positive. Next. If severe hypertension is encountered, that is a blood pressure of 160 by 110, then that requires urgent treatment within 1 hour of diagnosis. The drug of choice here is intravenous labetalol. The starting dose is low IV 20 milligrams, which is to be doubled every 20 minutes till a maximum dose of 80 milligrams is reached, and a maximum cumulative or total dose that is permissible is 300 milligrams. The second drug of choice for immediate control is oral nifedipine. It's not sublingual, it's oral nifedipine in a dose of 10 to 30 milligrams, and then it can be repeated every 30 minutes. The contraindications, however, are CCF and AV node abnormalities. Intravenous hydralazine is also a very good drug, third line, in a dose of 5 milligrams IV and then 5 to 10 milligrams every 20 to 40 minutes. Intravenous nicardipine is the new kid on the block. It is shown to have 100 times more water solubility as compared to nifedipine, so it may become more popular in future. The dose for it is 1.5 milligram per hour. The goal here is to achieve control of blood pressure, but not a very rapid control, but a slow and controlled reduction in the blood pressure, because we want to prevent side effects and serious side effects of antihypertensives also. Next. For seizure prophylaxis, the drug of choice remains magnesium sulfate. It is given in the same dose as we give for eclampsia, that is 4 grams loading, followed by 1 gram per hour of 1 gram per hour for next 24 hours. It not only achieves seizure prophylaxis, but also gives the additional advantage of neuroprotection for the fetus between 26 to 32 weeks of gestation. For hypertension which is refractory, that is the one which is not responding to IV labetalol or nifedipine, then the drugs of choice for refractory hypertension are nitroglycerine infusion or sodium nitroprusside. But preferably these should be given only in controlled settings, in monitored setting, typically HDO or ICU, especially sodium nitroprusside, because it runs the risk of cyanide toxicity if prolonged use is there. So these have to be used with caution. Next. In the postpartum period, the care has to be continued. Blood pressure has to be monitored for the first 48 hours, and natal antihypertensive therapy is to be continued. If the blood pressure is more than 140 by 90 or more, treatment has to be continued. If it is more than 160 by 110 or more, urgent treatment has to be given. Fluid restriction is very important. The fluid has to be restricted to not more than 80 ml per hour or more than 1 ml per kg per hour. The fluids of choice here are crystalloids, either normal saline or Ringer's lactate, because we know that excess fluid administration can be associated with pulmonary edema. The fluid management can very well be based on POCUS, that is point of care ultrasound. Nowadays, portable ultrasound is available in almost all ICUs. So they can ultrasound can be used to look for the IVC filling and left ventricular outflow, and accordingly the fluid requirement can be calculated. Next. The termination of pregnancy will depend on the condition of the patient. For mild occasional blood pressure without not needing any antihypertensives can be pulled to 38 weeks or even more. Chronic hypertension patient, again, who is very well controlled, can have a planned delivery between 37 to 38. If comorbidities are present like diabetes or obesity, then it is better to plan delivery at 37. For preeclampsia without severe feature, again 37 weeks is a good time to terminate. But when complications are there, any time between 34 to 37 weeks is good enough. Next. But then there are a group of patients who are going to need immediate delivery irrespective of gestational age. For example, when there is eclampsia or HELLP syndrome, severe hypertension not responding to treatment, when there is evidence of organ damage, or when there is DIC, or when there are severe fetal affection. In that case, of course, we do not wait for 34 weeks, 37 weeks. Patient may need urgent termination. Just 2 days back, we had a 29 weeks patient who had the baby was growing well, but then her lab started deteriorating rapidly and she developed very massive edema, and so she had to be terminated at 29 weeks itself. Next. Mode of delivery, I need not elaborate on this. All of us are obstetricians, so we know how to plan our deliveries based on the urgency, the Bishop score, gestational age, presentation, and the severity of the fetal affection. The induction of labor can be done by using prostaglandins or mechanical methods like Foley's. For IUD and anomalous fetus, misoprostol is better used for induction. Next. Next, a word of caution, prostaglandins and misoprostols are not to be used for a scarred uterus. Mechanical methods are better preferred. But for augmentation after amniotomy, I don't think we have any other choice apart from oxytocin. The choice of anesthesia is largely regional. So with safety advent of regional anesthesia, now regional anesthesia is the preferred anesthesia for preeclampsia, even eclampsia, provided the coagulation profile and platelet count are normal. Platelet count has to be at least 70,000 for us to give regional anesthesia. General anesthesia sometimes may be required, especially for fetal emergencies, but it is difficult because of laryngeal edema. So senior anesthetist has to be available in case general anesthesia is being given. Next. Now coming to eclampsia. Eclampsia is occurrence of seizures in a patient who is already preeclamptic. So any convulsion in pregnancy has to be regarded as eclampsia unless proved otherwise. So other causes that may be entertained if conclusive diagnosis of eclampsia is seems not so right, then epilepsy, brain tumor, intracranial hemorrhage, cerebral malaria, thrombosis, all these possibilities have to be explored, and very rarely TTP and HUS may also present as convulsions. Next. So all said and done, magnesium sulfate remains the drug of choice for prevention and treatment of eclampsia. All other drugs, phenytoin and diazepam and macpytrel and everything has proven beyond doubt that magnesium sulfate still is the drug of choice for eclampsia. The mechanism of action is stabilization of the neuronal membranes and reducing the cerebral excitability. Next. ABC is the first thing, and even before ABC, we must know that no doctor can treat eclampsia all alone. So calling out for help is the first thing, followed by securing ABC. Next. The treatment of eclampsia has to be a continued one. So the treatment should be simultaneous with control of seizures through MACSELF, control of blood pressure, monitoring the urine output, so putting in the Foley's catheter, having a look at the fetus, giving first dose of steroids, and then ultimately the only definitive management is delivery of the fetus, which has to be planned. Next. No, previous slide. So this is the most important slide. The loading dose of magnesium sulfate is 4 grams. So it is available as 50% solutions. So 2 ml has got 1 gram. So 8 ml of 50% solution will have 4 grams. So that is to be diluted with 12 ml, that 12 ml of distilled water. So that will make it 20 ml total. So 8 ml plus 12 ml, a 20 ml syringe is used to give it slowly over 5 to 10 minutes, and then 5 ampules, that is 10 ml in each buttock, will make it 5 grams in each buttock. It can be combined with lignocaine 1 ml. And then maintenance dose is 5 grams 4 hourly in alternate buttocks till 24 hours after delivery or 24 hours from last convulsion, whichever is later. Of course, we have to take a look at the respiratory rate, which should be more than 16. Deep tendon reflexes should be present, and output should be at least 100 ml in the last 4 hours. Nowadays, Zuspan regime, that is IV regime, is being preferred, especially in monitored settings like ICU, wherein 4 gram IV loading dose is the same, but after that, this is followed by 1 gram per hour IV infusion using infusion pump. So, infusion pump, if it is available, this is a very good regime. Nowadays, pre-formed preparations are available which have 4 gram of magnesium sulfate in 100 ml. So, that can be given over 4 hours. So 100 ml for 4 hours, and then only 6 of such 100 ml bottles are needed. So the fluid input with those bottles is only 600 ml, and the total dose of 24 hours is done in that. So that's a very good and easy to use option. Next. 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 So loss of deep tendon reflexes will occur at around 10 milliequivalents. The therapeutic dose is 4 to 7. Respiratory depression will appear at around 12, and patient is at risk of cardiac arrest after 20. So monitoring for magnesium toxicity is very, very important. And if respiratory depression or reduction in the respiratory rate is observed, then the immediate antidote is giving 10 ml of 10% calcium gluconate IV slowly, preferably with ECG monitoring. If the patient is having recurrent convulsions which are not controlled by magnesium sulfate, then one can repeat 2 grams of IV magnesium sulfate. If that also doesn't work, then other options are thiopentone sodium. Levetiracetam is showing a lot of promise. Levipil in a loading dose of 1 gram and then followed by 500 milligrams BDs really works very well, and many people are, although it is not mentioned in recommendations or it has not made its appearance in any of the guidelines, it is showing a lot of promise, so it may come in recommendations very soon. If this also doesn't work, then the best thing is to call your anesthetist friend, intubate the patient and knock her down with Atra and Midas, and then continue to electively ventilate her. Next. Postpartum hypertension is hypertension which persists or appears de novo in the postpartum period. Normally, the blood pressure should fall down after delivery because of blood loss and because of anesthesia effect. But if it persists, then we label the patient as having postpartum hypertension, which can be persistent hypertension. That is, if it occurs within 48 hours of delivery, or it can be a de novo hypertension if it develops more than 48 hours but within 6 weeks postpartum. Next. Next. Secondary causes of hypertension have to be looked for whenever postpartum hypertension is diagnosed. Next. The medicines continue to be the same, that is labetalol, nifedipine, amlodipine, even atenolol can be tried in postpartum period. Here, the word of caution is about methyl dopa. It is known to cause postpartum depression, so methyl dopa should be avoided in the postnatal period. Next. A short algorithm for postpartum hypertension management. If the patient is a known chronic or gestational hypertension, then we do routine labs after 48 to 72 hours. If the patient is not known chronic hypertension, then and if preeclampsia is diagnosed in the pregnancy itself, again routine labs at 48 hours, and then assess if the patient is stable or improving. If the patient is stable, patient can be discharged and followed up. If the patient is not stable, then escalation of hypertension or preeclampsia protocol has to be done. But if the patient is diagnosed to have new onset postpartum hypertension, then we have to do a systematic screen, just like for preeclampsia again. Look for the warning signs, symptoms, do all the labs. If it is found to be positive, then the patient has to be managed as preeclampsia pathway. And if no, then we have to ensure adequate analgesia, pain relief, and continue BP monitoring. Next. Next. Shortly about complications, in spite of all the screening and all the good management, some patients are unlucky to have organ failure, pulmonary edema, or HELP syndrome, even DIC. And the fetus may have preterm birth, which is mostly iatrogenic, low birth weight, IUGR, stillbirths also unfortunately occur in some of the patients. Next. Hemodynamic instability and previous one. Hemodynamic instability and associated obstetric complication like abruption or rupture of a subcapsular hematoma, all these have to be suspected whenever the systolic blood pressure falls below 100 or heart rate becomes more than 100, or if the urine output is less than 30 ml per hour, or whenever there is an acute change in the heart rate or systolic blood pressure by more than 15%. But then only heart rate elevation is not enough, because 97 percentile in normal pregnant people is approximately 115. So for some patients, 104, 108 may actually be normal. So other signs and symptoms of instability like altered consciousness, shortness of breath, cold clammy extremities, and pallor, all these have to be looked for. Next. As far as management of DIC is concerned, the first thing is to establish IV access with at least 2 wide bore cannulas of 18 gauge or more. And if the patient is hemodynamically stable, the immediate, the definitive mode of delivery for this patient is cesarean section. And if the patient is hemodynamically stable, then next thing to look for is whether the fetus is viable. Next. For a viable fetus with reassuring fetal heart rate, trial of labor can be given. But when the fetal heart rate is not reassuring, or when the fetus is not viable, again cesarean section is the best mode of delivery. So the risk of cesarean section is very high when the patient has landed up in DIC. Of course, FFP and platelet correction has to be given depending upon which parameter is affected. Next. Shortly about pulmonary edema management, the cornerstone of treatment here is giving high flow oxygen, 5 to 10 liters per minute, and giving diuretics. Furosemide 40 milligrams stat can be repeated more. 80 milligrams again can be given. If that is also not enough, then a continuous IV low dose infusion of furosemide can be considered. This patient will definitely require an intensivist because of the high risk of precipitation of CCF. This patient may need IV nitrate and IV dobutamine. But if the arterial saturation continues to fall, or if it is still poor in spite of high dose oxygen, then patient may even need ventilatory support. Next.
Bhakti, I think we are in short of time. Please continue.
Yes, this is the last slide, madam.
Yes.
Next. So I can conclude by saying that in the silent tides of rising pressure, that is high blood pressure, vigilance is the only guiding light that we have, and through timely care and gentle precision, we have to safeguard 2 lives who have every right. Thank you.
Thank you, Bhakti, for your excellent talk as usual and a very comprehensive. Indeed, it was a wide topic and you had covered it very nicely. You had right from the classification to the vestige score and risk scores, you had till delivery and everything you had covered. The take-home message is that vigilance, prevention is better than cure. So we have to be alert. And in spite of all this taking prevention, there are complications in some patients. So we have to be very vigilant, and we have to teach our obstetricians also to all the scoring systems and how to manage it. Your pharmacotherapy, you have covered all the drugs. So it without wasting much time, because we are in short of time, everything was covered. I think so. If there are any questions, we can take it after the session. Thank you very much for giving me this opportunity. Yes, Sheila ma'am, you want to add something?
Hello, I think excellent and very elaborative that even she covered till pulmonary edema.
Yes, exactly.
Yes, Bhakti.
Yes.
So, and and I must tell you that recently ICOG and Foxy, they have come up with a HDP guideline. I don't know. I will share it with Sneha, and Sneha can share with you all. And we have come up with a guideline, and which is suitable for our country. In that, we have mentioned about justosis score. Okay. Now, justosis is a simple calculation of the clinical findings, where if you find that the just score is more than 3, this patient, you have to start her on aspirin in pregnancy to prevent getting blood pressure. So now we have introduced it in Karnataka, Madhya Pradesh, everywhere, even in government, because it's very difficult to predict hypertension in such a large population. So I would like to request all of you to go through the guidelines and also to start using the Justosis score, because that will really help us. Okay. And I think Dr. Bhakti has almost covered everything. And now nicardipine has also come as a antihypertensive. So it is not easily available right now, but that is there. So what is most important thing is prevention. I think early detection and prevention, it is better, so that, and now let us see, after starting Justosis score in 1 year, we will know whether we are able to really reduce the burden of hypertension. The number of cases of eclampsia will also come down, because it is the number 1 cause of maternal mortality now in India, in most of the states. Okay. So I will share the guidelines with Dr. Sneha, and I think Sneha will share it. And that is the main purpose. But excellent talk, Dr. Bhakti. I think you covered everything. Thank you.
Yeah.
Thank you very
Thank you,
much.
ma'am. I mentioned in the beginning itself that my talk was based on HDP guidelines of ICOG 2026 only. So
I
they are
missed it.
excellent guidelines.
I missed it. Why? Because, I was giving a talk in another webinar.
Okay.
So then
Thank you,
I
ma'am.
was listening to you. Good, good, good. That is okay.
Yeah. So in fact, we have lots of interesting cases which you have already covered in your talk also. So I think it's better that we go ahead with the panel discussion at the earliest. So Pranjal, would you like to introduce the panelist? Darshan, can we have the CV slides?
Yes, ma'am.
So after this enriching experience on hypoglycemia and HDP, let us move for a panel discussion.
Start from the moderator, experts. Yes.
So indeed, we are very
Next
lucky to have. Okay, I'm audible. Am I?
Yes, yes. Darshan,
So
next
we are
slide.
lucky to have Dr. Sneha Buyar, madam, as a moderator, and of course, we are enriched with the presence of experts like Dr. Sheila Mane, madam, and Sangeeta Tajpuria. So I'll introduce the panelists. Darshan, panelist, please. Next. Okay, madam.
Okay.
Do we experts?
Yeah,
Darshan,
we are
please.
here. We are here. Yeah.
Yes. Yeah, they are already there. I think Pranjal, you can
Okay,
just introduce
so
them.
we have extremely talented delegates from our their own cities, like Dr. Meghna Agrawal, who is the secretary of OBGY Nagpur, Dr. Rucha Rajput Pode. Dr. Meghna Agrawal, she did her Dr. Rucha Rajput Pode, Secretary Chandrapur, Dr. Shweta Manvatkar, Treasurer Chandrapur, Dr. Manoj Aglave, Secretary Bandara. Darshan, you just keep on moving the slides. We also have Dr. Meera Aglave from Bandara. Next. Dr. Garima Madam.
From Gondia. Dr. Garima Bagga, she's an associate.
From Gondia, and Dr. Kiran. Yes, from Gondia, and Dr. Kiran Dhurve. So with this panel, Kiran Dhurve,
From
I'm
Yavatmal.
honored.
Secretary of Yavatmal Society. Don't worry, I will introduce. No worry.
Okay.
So
Okay.
she's the Secretary of Yavatmal Obsgani, and she's the assistant professor in the Government Medical College. So
Yes, Kiran used to be in Amravati, madam. Therefore, I got confused. Kiran
yes.
was there in Amravati previously. So from now, at present, at Yavatmal. Okay, next slide.
Darshan.
Done, ma'am. Done, ma'am.
Okay, so you stop sharing.
So with this panel, I'm sure that we are going to get lots and lots of take-home messages. So Sneha, madam, over to you.
Yes, thank you so much. Just allow me to share the screen. Yeah. I hope you can see my screen. Yeah. My apologies. Today my throat is little bad, and I hope you can just hear it's a little hoarse. But yes, I welcome the experts, Madam Sheila Mane and Dr. Sangeeta Tajpuria, and I welcome all the panelists. So, friends, I'm sure all of you have experienced this scenario in your labor room. You feel that, she's delivering vaginally, and within no time, all of us will be free and everything will be nice. And next few seconds or few minutes, you find her in ICU. That is a scenario sometimes. I'm sure this is the best picture that can explain that how what is the gravity of the situation and the urgency of intervention it demands. So this is actually near miss. So this terminology we have borrowed from the airlines industry, and this actually gives you the gravity of the situation and the urgency it demands. So near miss is defined as actually, I hope I'm audible, Pranjal.
Yes, ma'am. Yes.
So near miss, actually, it is also called as SAMM, severe acute maternal morbidity by WHO, and it is defined as the critically ill pregnant who is pregnant woman or a recently delivered woman within 42 days. Had it not been the luck, she would have died. Had it not been the luck or the good care on her side. In fact, we have to share with each other and we have to discuss such near miss cases so that we can assess the quality of the services we have provided, and we can have points to areas of improvements and interventions. So SMM is actually a terminology by WHO and tells you the preventable maternal deaths. And according to WHO, for India, it is 8.23%. So, friends, we have been all the time talking about maternal mortality rates. So, these are not only statistics, rates, so ratios, and figures. These are women. They have their faces, and we obstetricians have seen them in the faces of distress, despair, and agony. And these faces keep on haunting our dreams. That is how it has been expressed by Professor Mohammad Fatala, who is the past FIGO president. And similarly, it has been expressed by Ian Donald that over looking back over the long clinical times, one tends to forget or to the failures, in fact, take the success for granted. That it is the failure that stands like a keloid, and it's like a warning to the person who have faced and a reminder to the others rather. In this present era, I'm sure because of the changing demography of the obstetric population, this magnitude has definitely increased, but at the same time, the spectrum is widened. And that's the reason. All of you know, for the obvious reason, I have already talked about changing demography. That means we have the advanced maternal age, because of the career-minded, women-centered society now, the sedentary lifestyle, the increasing obesity, and the resultant infertility, and then the ART and IVF procedures, the complications associated, multifetal pregnancies, and of course the age-related surgical and medical morbidities definitely leads to increase in the placental complications as well. I'm sure we always talk about obstetrics is unpredictable. So every case is new and it teaches you something. So friends, let us all learn together. So never stop learning because life never stops teaching us. So with this, we start with the first case. I'm going through the cases, little fast. So Dr. Meghna, this is the first case for you.
Yes,
We
ma'am.
second gravida, she's got first LSCS. The child is only 1.5 years old, and she comes to you with 7 days overdue, UPT positive. She requests the doctor. She goes to her family doctor, and he or she prescribes her medical abortion pills and sends her home. To come back after 7 days. On sixth day at around 1 a.m., she is brought to the hospital in a collapse condition. So on further inquiry, there's no history of excessive bleeding at home, no history of severe pain, only spotting and fainting attacks. So when you examined, she's got tachycardia, blood pressure is only 17, she's severely pallor. I'm sure you got the diagnosis. What is the differential diagnosis here? What investigations you will do, and how would you proceed ahead with the management?
Yes, ma'am. Thank you, ma'am, for the question. She appears to be a case of ruptured ectopic pregnancy because the medical pills were given without an ultrasound being done, first trimester ultrasound.
Right.
So yeah, so she has come to me in a collapse state.
You mean
Definitely
to
after.
say, yeah, you mean to say tubal ectopic or something else?
Ma'am, it can be tubal ectopic, it can be a scar ectopic
Yes.
because she has a very short interconceptional period, only a 1.5 years old child.
Right.
So first is the resuscitative measures after she is stabilized, definitely an ultrasound to diagnose where is the ectopic pregnancy, either tube or the scar pregnancy.
Hmm. Do we wait for her to get stabilized for such patient? Or
No,
you
ma'am.
easily
By the
manage?
time, yes, side by side, all the things go
Yeah.
side by side.
Yes.
The blood is, yes, the blood is called for. By that time, the fluids are running. And
Hmm.
at the same time, we are doing the ultrasound to confirm where is
Yes.
the ectopic. And then accordingly, depending upon the location, it can be a scar ectopic, it can be a tubal ectopic. For a
Right.
tubal ectopic, the treatment is very clear, immediately surgery and
Hmm.
salpingectomy. For a scar ectopic, and in this situation, the
Whether
management
laparoscopy or laparotomy.
for tubal ectopic.
Mm-hmm.
I mean, in this case, I will go for laparotomy
Okay.
because she is totally unstable
Mm-hmm.
and she will not give me that much of a time to put in the CO2 and then do the laparoscopic surgery. I would
Oh,
rather go ahead with the laparotomy.
any difference of opinion from the other panelists? Suppose you have an expert laparoscopic surgeon at your disposal and who is available there, or maybe you yourself, if you are an endoscopy surgeon and if everything is available, then definitely you can go ahead, because nowadays people say
Yes, ma'am.
you just go ahead with the suction, catch hold of the bleeding point, and that's all, right?
Yes, ma'am. But it
Yeah.
all depends upon how fast the patient is stabilized, how
Mhm.
fast the blood is available with us, and how much time the patient is giving us.
Yeah, it will all depend upon your comfort and your convenience, whether you
Yes,
are
yes.
expert in open, you are comfortable with open or the laparoscopy.
Yes. So,
Right.
ma'am, because here the important point is to save the patient's
Yeah.
life.
Perfect.
So at that point, whatever is the best approach, laparoscopy or
Yes.
laparotomy, but
Mhm.
surgery is the answer.
So that is why, because in good old days we used to say no, no, open, because you get everything at your, you can see, you can touch. But nowadays, if you have everything at your
Yes.
disposal, and if you have an expert endoscopic surgeon, definitely you can go ahead with laparoscopy also, right? Because that
Yes.
is how we have been managing regularly, right?
Yes, ma'am.
Whether you would go for salpingectomy or you will conserve the tube.
Ma'am, I will go for
Right.
salpingectomy because a tube which has ruptured is not worthy to be kept.
Correct. That is what is the message we have to
Yes.
give, that we have to resuscitate the patient, arrange for blood product, arrange for operation theater, take her for surgery, and whatever surgery you are used to, you are comfortable, go
Yes,
ahead.
ma'am. Salpingectomy.
Right.
Yes.
Now, the last question, of course, what are the lessons learned? Where do we go wrong for this patient? What was,
Yes, ma'am.
yeah.
Yeah. The location ultrasound has to be done
Hmm.
before giving the MTP pills. Maybe if the local doctor had advised an ultrasound, this midnight emergency could have been avoided
Perfect.
because the sac would have been picked up earlier and accordingly the management would have started.
Right. So,
Can I add something,
yes,
Yes,
Sneha?
yes, madam, definitely. I'm coming to you for the end of this.
So
Yeah.
one more thing I will tell you, when we are doing the scan, sometimes you see the scan, it could be a pseudo sac with
Right.
ectopic. So not to forget to look at the adnexa.
yes, ma'am. Definitely in every
Always
first
look at the
trimester
adnexa
scans.
also, because sometimes this could be pseudo sac and
Pseudo
thinking
sac.
that it is intrauterine. And one more thing is, if you are not able to make out it properly, recently I had, it was
Okay.
it turned out to be a rare, that is, I'm just sharing. It turned out to be an invasive mole.
Oh,
And when I
good
got her
case.
beta HCG done, it was 27,000.
Wow.
Because I gave her medical abortion pill thinking there is a sac. She didn't bleed at all.
Hmm.
When I did a repeat scan and I put a Doppler, I said, what is happening? Why this is not? There was full of vascularity. I got a beta HCG and it turned out to be a invasive mole. So that pseudo sac, one has to be very careful. Look at that. Have a look at the admix always.
Right.
Yes,
So
ma'am.
the message very well delivered. We have to go for ultrasonography before prescribing the medical termination pills, because even though it is not mandatory by law, it is recommended for the safety of the patient as well as for the safety of the doctors. And as Madam has said, yes, careful pelvic ultrasound, intrauterine or extrauterine. So you have to look for the adnexa very carefully. Right. So that is how, this was just a warming up case for you. So we go ahead with the next case now. This is the second case. We have this 36-year-old, obese woman, infertile for 7 years. She conceives with IUI. Her husband is working in Dubai and she stays in a village. But because it's a precious pregnancy, she comes to the obstetrician regularly for NC checkup up to 24 weeks, when the obstetrician tells her that everything is fine. And now she's lost to follow. At 34 weeks, she reports to a PHC with pedal edema and pain in abdomen. So the medical officer examines her. Blood pressure is 176 by 116. So he thinks that, it's a hypertension. He just gives her a tablet nifedipine retard, because that was the only thing available there. And he tells her that it's a high risk pregnancy. You have to go to higher center. So this lady did not go to the higher center on the same day. In fact, 2 days later, she reached to the district hospital, where they just examined her. They just added tablet labetalol 100 milligram in addition to the nifedipine retard. They gave her magnesium sulfate, and because they had anesthetists and operative facilities, they took her for cesarean section. So 1.8 kg live female baby was delivered. But persistently, this patient's blood pressure remained between 140 to 180 systolic and 100 to 110 diastolic. And this patient suddenly, after 10 hours, started feeling restless, breathless. Her pulse rate was 150. Blood pressure was 220 by 118, and the oxygen saturation dropped to 70%. Her chest was full of wheeze, no clear breath sound. So, Rucha, what is your differential diagnosis for this patient, and how would you manage this patient? Dr. Rucha. Do we have Dr. Rucha? No? Okay. I thought I saw her. Okay, we can have Dr. Manoj or Dr. Garima. Anybody can take up, in fact.
Hello.
Yes, Manoj.
Good
Please.
evening, madam.
Good evening. Good evening.
After 10 hours, she is having persistent high BP, and there is a wheeze on. It may be a case of pulmonary thromboembolism,
Okay.
or it might be the case of peripartum cardiomyopathy in differential
Yes.
diagnosis.
And
Or
related to this,
ARDS, adult respiratory distress syndrome.
yes,
Or
Garima.
pulmonary edema because of max
Right.
sulfur.
Good evening.
Right. Yeah, good evening. So,
As the patient is high risk, she is hypertensive, edematous, elderly, maybe in differential diagnosis, we can add pulmonary edema as the common cause of severe preeclampsia, common complication of severe preeclampsia.
right. So, in fact, considering the case history, pulmonary edema will be the first differential, but definitely, as Dr. Manoj has said, it can be pulmonary embolism and even a catastrophic presentation of PPCM, peripartum cardiomyopathy. Definitely, you have to go for management and investigation simultaneously. So, how would you go ahead? Manoj, would you like to continue?
One more study has come where they say that if the patient is hypertensive, postnatally, postoperatively, we can give them Lasix every day,
that
at least for 3 to 5 days, because that will reduce the chances of pulmonary edema.
Yes.
And one more thing is fluid restriction.
Yes.
Very important in this.
So for this catastrophic presentation, we will first manage this patient.
So we have to stabilize the patient.
Mm-hmm.
As per the protocol, we have to already patient is catheterized. Then we have to give the oxygen.
Yes.
And if she is in failure and her BP is on higher side, so there is no role of inotropics. We have to give the Lasix in such cases to reduce the pulmonary edema.
How
And
much?
with the
How much
oxygen,
Lasix?
initially we'll start with the 40 milligram. And if the saturation is not improving and
Yes.
wheeze is continuing, then again we'll give the 40
Mhm.
up to 120 milligram.
Right.
We'll give
So
her.
40,
And if
80,
the
so definitely, yes.
definitely,
Then,
and we have to look for the urine output. And if her saturation is not improving, we have to intubate such patient and accordingly shift such patient to ICU.
yeah, but anything
And
before that, intubation definitely will come to it. Suppose this patient, you gave her immediately propped up, you gave her Lasix, you gave her oxygen mask. What else? Her blood pressure is very high, Manoj.
We can,
we
ma'am,
have to
we
give
can
the
go for
antihypertensive such patient IV labetalol or nitroprusside.
Yes.
We have to control the
Which
BP.
one you will prefer?
Labetalol injection. Right?
Actually,
And
see, for this patient, because we are obstetricians, we have been talking about Lasix. But when you talk to the intensive, yes, nitroprusside or
nitroprusside is the
infusion.
choice.
These are the two preferred drugs because she's in pulmonary edema, in fact. Okay, so we, for us, severe hypertension, the treatment drug of choice is labetalol. So we give labetalol initially. How do you give labetalol? Have you ever used IV labetalol? Kiran?
Yes, ma'am. Injection labetalol IV, we give 20 milligram of IV labet we give, injectable.
Yes, yes. Wait for.
Uh,
How do you give? How do you give?
Yes, ma'am. Slowly we need to give it at least for 10 to 20 minutes. Slowly
Yes.
we need to give it and we have to check for her vitals along with that.
Yeah. So basically, labetalol IV takes at least 10 minutes for its action. So whenever you give the initial dose, wait for 10 minutes and then you give double the dose. So 20 when you give initially, give 40, give 80. But you can repeat 80 only and not beyond that. Though the maximum dosage is high, 320, we should stop at 80 and add another antihypertensive. That is what is the dictum. So see, now this patient, we have given her everything. We have given her antihypertensives. At the same time, she immediately, she becomes pulseless. Her oxygen saturation further drops to 55%. And on AMBO-assisted respiration, this patient was shifted to ICU, which is just closer to the labor room. But the patient went into cardiac arrest. Now, how do you manage this patient? Anybody can take up. This is an open question.
We need to immediately intubate her and need to shift her to ICU. She is already in ICU actually.
Yes.
And
yes.
ventilatory support she will be needed further.
Yes. What is CPR and how do you give that? Because she is in cardiac arrest, right?
Yeah.
We have to give injection, adrenaline injection. We have to start injection dobutamine. We have to shift her on inotropes and vasopressors.
Yes, yes, Garima. But what is CPR and how do you give it? Drugs, definitely. But because she is in cardiac arrest, we have to resuscitate her with CPR, cardiopulmonary resuscitation. So how
Hello?
many comes and yes, yes, Meera.
Ma'am, Meera here.
Yes,
I'm sorry, for CPR,
Yeah,
first
rapid
you have to
your
do
CPR, go
ABC,
ahead.
airway
Yeah.
breathing circulation. Hello?
Right.
ABC, ma'am, airway breathing circulation. First, we have to maintain her airway. If we
Mhm.
can manage with a regular airway, a Goodell's airway, then we can use that. If it is not working, then we'll have to intubate the patient and ventilate first with umbu bag. And then later, as soon as possible, shift her on a ventilator. Next, we have to check her breathing. We have to check her saturation. We have to do her blood gases and see if she is getting enough oxygenation to maintain her vital organs. And third is circulation. We have to check her pulse BP. If she's pulseless, her BP not recordable, so we have to start chest compressions and we have to manage the patient. If required, she might require defibrillation. So since she's already in an ICU, we can keep all that ready. Get
Yes.
team effort, get the intensivist on board, get the anesthetist on board, and manage accordingly.
Yeah. So this is actually the respiratory part you are managing, but what we are talking about is cardiopulmonary resuscitation. So whether this patient of cardiac arrest needs CPR? Does she need CPR?
Yes, ma'am. Of
So
course,
how
of
do we
course.
give it? So, Mira, I'm sure you will be able to say that. How to
Adrenaline, atropine, soda bica, ma'am. These are the main.
But what about the cardiac, the chest compression?
Chest compressions. Yes, ma'am. I mentioned chest compressions. We have to start chest compressions immediately. We have to keep both our hands locked like this. Keep our the base of the palm on the sternum, right at the
lower
base
part
of the sternum.
sternum.
And with our elbows extended, we have to go from the waist onwards, downwards, and push the chest up to 2 inches or 5 centimeters
5
inside,
centimeters.
and continue doing it. Preferably keep the
And
patient on a hard surface.
how many compressions? How many
30 compressions in and in between 2 breaths.
2 breaths.
30.
Right. So that is what I wanted all of you to know, that because this is the first thing as a reflex we have to perform whenever the patient goes into cardiac arrest or cardiorespiratory arrest. And then of course your team is there to give the drug and other, assist this breathing as well as circulation. Madam, do you want to add anything here in the CPR and initial resuscitation?
See, one more thing is diagnosing pulmonary edema very early. Must do the oxygen saturation of every patient who walks in with high blood pressure.
Right.
If it is below 95, it is a warning sign to you and a tachycardia. You will not get any adventitious sounds on RS examination. But if the patient's saturation is low, immediately you know that you have to manage this lady for pulmonary edema. Sometimes we get antenatal patients who are already in pulmonary edema, and nitroglycerin is a drug of choice, but it won't be available in your emergency drug. The basic, whatever we discuss here, you go back and see whether in your OT, in your emergency bag, where there is an ambu bag, where the anesthetist is going when you initiate the code blue, do they have nitroglycerin? They don't have. Okay. So these are the things, when we do the debriefing only, we come to know that, yes, we should have had this. So intubation is very important. These patients require intubation immediately. You have to intubate them because they will not maintain the saturation and they will collapse very soon. And management of hypertension and all other ventilation, everything you will have to take. And furosemide, all of us we know. And for labetalol, she already mentioned rule of 20. Okay, you will have to give it 20, 40, 80. Then every 20 minutes you go on giving 80. You can go up to even 220. Okay, so that much. And if when it is not controlling, you will have to go for other antihypertensives also. But that is how the pulmonary edema is managed. So early detection is very important. Breathlessness is not at all a good sign. Any patient coming to OPD and she says, I am breathless, admit her. Admit her, we are missing something, and they come back next day, or sometimes they are brought dead. So it's very important.
Yes. So our patient, you have given propped up position, oxygenation, you have given Lasix, you have given antihypertensives, and she, in spite of that, she went into cardiac arrest. You have given CPR to her, you have given her epinephrine IV, and if she requires repeatedly every 3 to 5 minutes, and this patient was revived. Okay, so now let us introspect what went wrong for this patient who, regularly registered patient coming to you for regular checkup. What went wrong where, and what's this preventable? I would ask all of you, and I want the input from everybody, right from early pregnancy, obese infertile woman who conceived on IUI. So what went wrong? I think start from Garima, right from early pregnancy. What we missed in the history, HDP testosterone score. Okay. Please say, Garima, I want inputs from all of you. One point. Hello?
Yes, ma'am. Yes, ma'am.
Yeah.
Ma'am, from early pregnancy, she should have started tablet aspirin, and more frequent antenatal visits should be there.
Yeah, that she was coming to regular ANC visits. Okay, but yes, as I said, in the history, we missed that she was 36-year-old, so elderly gravida, obese, and maybe we have not done her it's not mentioned TSH, but if at all. So HDP justosis score, if we have done, then she was high risk. We could have started low dose aspirin and high dose calcium. Kiran, what next? Any prediction during early pregnancy, biophysical, biochemical?
Yes, ma'am. Actually, the scan is not mentioned, which was done, which we do at first trimester NT scan. Along with that, we do the screening for preeclampsia. That was not mentioned here. If at all that was done, so we could have predicted the case that she is a high risk. She may land up in preeclampsia.
Yes, so uterine artery pulsatility index at 11 to 13 weeks, PLGF and SFLT score, the ratio. Okay, and she was told that everything is fine at 24 weeks. Dr. Manoj and Meera.
Hello.
Yes, how should have been the follow-up for this patient?
Regular BP checkup is most important. In every visit, patient should be checked for blood pressure.
Right. So
And
basically considering her as high risk, we should never tell the patient that everything is normal. The patient misunderstands it, that everything is normal. We need not come for regular follow-up now. That is what has happened with her. And it's not the first trimester. In fact, blood pressure usually rises during second and third trimester. So she has to be warned that you need to come back regularly, frequently, so that we can keep a watch. And when she was, when she reported to PHC for the first time, her BP was 176 by 116. So what could have been the advice and the treatment?
She should have admitted on that BP only, ma'am, because she comes under now. This is the range that she falls under severe hypertension. I mean severe preeclampsia. She should be admitted that and that time only.
Yeah. So she was at PHC. The PHC could have carried her, in the ambulance.
She should be referred to the higher center.
Right.
Under the observation of gynecologist.
Yes. And was it the SDH where she should have been operated? Just because they had operation theater and they don't have HDU ICU. So such patient needs to be followed up or monitored for 72 hours at least, right? So wherever the facilities for HDU and obstetric ICU are available, there only such high risk patients should be admitted. It's not only that, even today the SDH and PHCs where they have OTs and anesthetists, they go for cesarean section. But if it is a routine, that is fine. Otherwise, for a high risk patient, this is the result, right? So she was mismanaged at all levels, and that's a very reason. See, this is what we have already. Even intraoperatively, the preload which we give for cesarean section, that could have been avoided. Immediately after delivering the baby, we could have given her Lasix as a prophylaxis because now the baby is out, right? So not to give Mithergine and even prostaglandins and give Lasix. So this is how we could have avoided this catastrophe. So with this, we go ahead with the third case now. We have this XYZ, primary gravida, 9 months, 9 months amenorrhea, and she was referred from a nearby nursing home at 3 p.m. She was having labor pains 3 to 4 hours prior to the admission, right? And as there was failure to progress, this patient was taken for cesarean section. So the sister catheterized her bladder. There is absolutely no urine output. So she informed and she inquired with the patient. So last 12 hours since when she was admitted, there was no urine output. Now they got that she's into anuria mostly. So they referred her to tertiary care center. When she came to the tertiary care center, the blood pressure was 110 by 70. Tachycardia, uterine contractions, very severe in intensity, no relaxation in between. Fetal heart was hardly 100 per minute. Cervix was only 3 centimeter, membranes absent, station -2, and pelvis adequate. This patient, this is the clinical picture. What is your diagnosis? I would ask the panelists. Dr. Shweta.
Good evening, ma'am. This is a classic obstetric emergency case. And as a case summary, we have the patient with 20 years with primary gravida, term pregnancy, and referred case. So key points are strong labor pain and failure to progress, posted for LSCS. She is having anuria after catheterization, severe abdominal pain with tachycardia, pulse 110 by 110 per minute, fetal heart rate.
What is your diagnosis here?
My diagnosis is primary diagnosis is concealed abruptio placentae with cochlear uterus leading to DIC. And the reason for this
The
is
DIC has
as
not given you the findings. That is in the next case. But here definitely yes, abruptio placentae grade 3 with severe fetal distress, right?
yeah.
So her investigations were done and hemoglobin was 8, platelet were 1 lakh, PT-INR was 2 and APTT was prolonged. FTP was present and fibrinogen was only 150 milligram percent. So she is in early DIC definitely. So whether she is already in DIC and she is having fetal distress. So whether you would immediately take her for fetal cesarean section to save the baby, how would you go ahead with the management? Whether you would
No,
wait for, yes, go ahead.
this is a life threatening emergency for both mother and fetus. So immediate multidisciplinary approach is needed. And this is a general medical information, and any patient with these signs needs urgent evaluation by an obstetrician and intensivist.
I have asked you a
So
very simple question. I have asked you no theoretical answers. Whether you will take her for
Okay.
immediate LSCS or you will wait for the blood and blood components.
We will wait for the blood and blood component.
Why?
We have to stabilize first the
You know that
patient.
once the placenta is separated within next 5 minutes or maybe 10 minutes, you will lose the baby.
Yeah.
So whether you want to wait still. See, the
No,
levels are not very bad. Platelet count is 1 lakh. A PT-INR is 2. But even fibrinogen is still 150. She is in early DIC, definitely. So,
In
yes.
such cases, madam, we have to
Without
counsel the relative.
we were to do LSCS without correcting the coagulation as much as possible, because otherwise that may lead to death on table, as she is having anuria, which is a bad prognosis, and it indicates the renal cortical necrosis also.
So my question again is whether you will wait for the blood and blood component or you will aggressively resuscitate the patient, because what happened because of the hypovolemia. Okay, she is in hypovolemic shock even though her blood pressure is 110/70 now, which you feel is normal, is not, because she may be hypertensive, because of which she has landed up into abruptio. But hypovolemia, even if you correct it with fluids, IV fluids, aggressive fluid resuscitation, you can correct the hypovolemia, correct. So it's not that you don't arrange, but you arrange for blood and blood components, make OT arrangements and take the patient for cesarean section simultaneously, so that by the time you deliver the baby, the things are available and then now you start correcting. If it was platelet count less than 20,000 or maybe the fibrinogen is also very less and she has got bleeding tendency, of the clotting time is very prolonged, then it could have been, that it's we have to save the mother's life first. That is what the modern obstetrics says. So here, aggressive fluid resuscitation, correct the hypovolemia, don't allow the patient to go into irreversible renal failure, deliver the baby, and then now, because APH is usually followed by PPH. So you manage prophylactically the PPH also. That is how it is. So I would ask madam to comment. Yes.
Yeah, I think this is a very complex case. One thing is she is in early DIC. The surgeon will be scared when I operate. I may not be able to control the bleeding, right? Okay. Right. Another side, the baby is need to be saved. So you have to. Now the INR is 2. That means she has really bled enough inside. Okay. Now this has to be managed in a place where there is a blood bank backup.
Yes.
Otherwise, it will be a very. But now I would like to tell you that injection fibrinogen concentrate is available. What we do is, because the blood and blood products will take time to come. So you can give, and these patients, see, actually we need it more than 200. This is 150, okay. But if we can give her fibrinogen, at least PRBC can be given immediately, because PRBC will improve her oxygen carrying capacity, right? Platelets are okay. But as her INR is 2, that means definitely she will require massive transfusion. You will make all the arrangements. You will have a expertise. but fibrinogen injection is available now. And when we talk about DIC score in pregnancy, the maximum marks in that, what we take there is PT, platelet, and fibrinogen. And for fibrinogen, the score is 26 if it is low. Okay. So if the fibrinogen is low, your score is so high, and this patient requires massive injection fibrinogen. It costs 10,000. And I'm happy to share with you that in Karnataka now, we have given instructions to all the district hospitals to keep at least 2 or 3 vials of fibrinogen ready, because they have only blood storage facility. Even if you are in a private, in a nursing home, you are shifting the patient, give her fibrinogen and shift. She will not go in for severe DIC. So we are using fibrinogen, 60 milligram per kg body weight. It costs 10,000, but it is worth because you can really save. Particularly in abruptia, when I used 2 grams, there was hematuria, it got cleared. Okay, and abruption goes for early afibrinogenemia because the clot consumptive coagulopathy. Clot will consume everything. Okay, so or try to get the blood and blood products as early as possible.
Yes. So the abruptio delivery interval is very, very important. That you have to take into mind. And definitely, as Dr. Manoj has said, that your one team has to be in touch with the patient's relatives in counseling of the relatives, and informed written consent of everything is very, very important, because whatever you say and whatever you do, it has to be documented. So that we have to take care. So this is a case of very clear-cut abruptio placenta. You need blood and blood product. So looking at this values, what blood components are required, Shweta?
We need platelets. We
Ma'am,
need
I already told you, fibrinogen.
fibrinogen.
Yeah. What should be the optimum level, optimum concentration?
Optimum concentration of this less than 150. If it is less than 150, then we have to give, for example, this is a fibrinogen with more than 100 mg. Now the FFP.
Okay.
Fibrinogen here, we have to give 10 units if fibrinogen is less than 100 milligram %. And FFP, we have to give
What will be the optimum fibrinogen? I'm saying, when does the patient start bleeding? I mean, what is the optimum level? If it is less than 300 milligram %, if it is less than 300 milligram %, the patient, has a bleeding tendency. So you have to correct this. So what component you want to give and how much?
We have to give FFP 15 ml per kg immediately, which is equals to approximately 4 to 6 units. And this gives all clotting factors. Then we have to give platelets, which is 6 to 8 unit, as count is 1
For
lakh.
this patient, you don't need to give platelets. It's already 1 lakh.
1 lakh.
Fibrinogen, that should be good enough. And as we said, it can be either FFP or cryoprecipitate, whatever is available. But packed cells, packed RBCs to improve.
Packed cells, we have to keep ready for 2 to 4 units, and we have to avoid crystalloids.
Right.
We have to avoid crystalloid. It will worsen the dilutional coagulopathy.
Can I just add?
Yeah,
now
yes.
The newer trend is, like, whenever you think that the patient requires massive transfusion, is immediately you won't get cryo, you will give FFP. Now FFP contains all the coagulants, okay? And the fibrinogen is very low. It is only 0.5 gram per liter. Okay, it is only 0. But if you give cryo, and cryo also, how much you have to give? You have to give 1 pool. 1 pool is 10. 1 pool is 10 bags. Now volume of FFP is 200 ml. And volume of cryo is 50 ml. So if you have to correct the fibrinogen, you will have to give multiple, which will again cause hemodilution. And because you are giving more volume, the fibrinogen level. So whenever now there is a need, now we say 1:1:1, the last one is added early.
Yes.
So that you are giving cryo. And cryo contains more number of fibrinogen. It has factor 7, it has factor 8, it has factor 2. So because that is required for coagulation. Okay. If you have fibrinogen, yes, you give it. Okay. But otherwise, you ask for cryo, give 10 pulls. So hers is 150, optimal level is 200. Okay. So if you give 150, then you can give at least 5 bottles, 5 bags. That will go beyond 200.
Yeah.
If it is still low, you give 10. And so the cryo is preferred. So the recent trend is don't go on giving FFP. FFP causes trali also. More
Yes.
chances of trali with FFP. So give
Hypo.
cryo. Yeah.
So we go ahead with the next case now.
How many cases are there?
I think we take this as last.
Okay, because I have to join for Gurukul also now.
Yeah. Last case. We are already late. So 32-year-old para, one previous seizure. She's got first child, male child, 1 year old. Now this time she, during 6 months of pregnancy, she comes to your hospital. She comes to the city for the first time, unregistered patient. She comes to you with history of bleeding. When you examine her, you find that she's got 26 weeks pregnancy, and she gives you history of early pregnancy spotting also. So ultrasound, tells you that placenta is low-lying and there is absent RP lake, there is hypervascularity, vascular laminae running towards bladder, and anomaly scan is normal, NAD. So at 30 weeks, again, she starts bleeding at home significantly, but stops. So they bring her to the hospital, but while getting investigation, she collapses. What is your diagnosis, Manoj, and how would you manage this patient? Then we last discuss whether we could have prevented this catastrophe. Okay.
She is a 32-year with a previous LSCS patient with history of spotting, and ultrasound shows early low-lying placenta. And on ultrasound at 26 weeks, it shows the hypervascular placenta with vascular laminae running towards the bladder. This is a case of placenta increta.
Yeah, towards bladder, so can be percreta.
Increta also.
You can
And
see.
at 30 weeks, she came to the hospital with heavy bleeding and she collapsed. So this is the case of placenta previa with a hypovolemic shock because of hemorrhage, antepartum hemorrhage.
So how will you
we have
manage
to
this
manage.
patient? Now, in this catastrophe, how will you manage? Whether you will try to conso or you go for operative procedure? That is the basic question.
In such cases, first we'll stabilize the patient.
She's collapsed. She's bleeding.
So she's collapsed. So we have to first stabilize her. We have to call for help.
Bleeding continuously, she will not be stabilized. No?
It should go on simultaneously. That
Directly, we cannot rush
resuscitation
patient
part and
to
shifting
the
to
operation
OT part.
theater.
Okay.
First, we have to shift the patient to the ICU. We have to call for it. We have to take the help of intensivist anesthetic. We have to arrange bloods, catheterize the patient, secure IV line,
right.
Then give oxygen. Try to manage. Then assess her condition, and if give her tranexam and all these drugs. Do her blood investigations. After doing that, if her condition is not improving and her bleeding is continue, then after counseling the patient,
she is not responding. She is bleeding continuously because it's a placenta previa, no? So she is bleeding continuously. She is bleeding continuously, and yes, and she's in shock.
But, what happened, madam, if we directly rush such patient to the operation theater,
after the initial arrangement, after the initial management, you have put into IVs, you have arranged blood and blood products, you have anesthetist, intensivist, everybody with you, but she is worsening, not even maintaining. Okay.
He is worsening, but in such cases, what happens if you directly post such patient for the operation, and if some complication happen, patient
No, we are not talking about directly. We are not talking about directly. Now we are talking. We have tried initial.
Simultaneously, after arranging all this section and with the patient relative consent and everything, explain the risk of.
What you will explain them?
In such cases, we will also explain the need of blood products, then removal of the uterus, that is hysterectomy, obstetric hysterectomy, and even the need of ICU and maternal death if her condition not improve because of hypovolemia.
What about baby?
Baby may need the NICU care. or as per her.
About the survival, they will ask you, सीजर करता है बाढ़ मिलेल कि नहीं मिलेल?
Even say she is a previous LSCS, placenta is low lying, so definitely 3 centimeter. I think depending on our cervical or status.
We are not looking at mother. We are looking at baby right now. No, we are not looking. Sorry, we are not looking at baby right now. We will look only at the maternal health.
That is what I'm saying.
Only a mother.
Yeah.
So you have, see, even if it was not placenta previous season, 30 weeks baby, whenever we are tackling such case, we have to tell them that we cannot assure, right?
Yeah.
We have to try our best that, yes, best of the neonatologists, best of the NICU facilities, but there is a guarded prognosis for the baby for sure, right? For the mother, we have to see, you have to tell them that whatever operative procedure we are doing, it is for mother's life, not for baby.
Babies.
Right? Huh. Okay. Now you tell me. Okay. So we go ahead, Garima. Suppose now Manoj has tried to stabilize the patient, or everything has been done, all the arrangement has been done. Now you want to take the patient to operation theatre. So what special precautions you need to take for this patient's operative procedure? What special precautions?
Ma'am, pre-operatively, as sir has said, all the necessary arrangements have been done and now patient is shifted.
Yeah, during the procedure. What?
That is pre-operative. Intraoperatively, if we will come, we are sure that it is a placenta accreta spectrum. It is placenta percreta as it is going towards bladder.
Yeah,
so I
yeah.
will also make sure to call the urosurgeon at least when I am
So
operating.
how many people you want in your team in addition
I
to
want
obstetrician, anesthetist, neonatologist? 3 we have.
Yes.
Vascular
Meanwhile,
surgery
I
is
will
also.
start performing the obstetric hysterectomy, and if
No,
and I will also call.
beforehand. You need this team beforehand, right?
Yes, yes.
Yes. Okay.
Matlab,
So who
while
else?
operating only, I will tell one
Yes.
candidate to call the
Somebody to-
urosurgeon also, because
Yes.
it is going towards the bladder, because after hemostasis and after doing hysterectomy, we have to look
Perfect.
for the bladder.
Perfect.
Second thing is also is I will not try to separate the placenta and pull
No,
out
we are
the
not. We are
placenta.
not on that. We are still assembling the team. Everything has been done. Anesthetist is giving the anesthesia, but you are 3 of you already, and you have now invited the urosurgeon. Who else?
Physician also.
Intensivist, yes. Who else?
Vascular surgeon is also important. Cardiothoracic surgeon.
But we don't have, no. We want, no. As a part of
Interventional radiologist.
Yes.
Interventional radiologist.
Yes. So not vascular surgeon. It can be even a general surgeon or a neurosurgeon or a oncosurgeon. It should be okay. But definitely, if you have the facilities, interventional radiologist. Okay. So you have. And what about blood bank?
Yes.
Blood bank also.
Yeah.
We may need to inform the
Now
blood
you
bank
have
that
assembled
they
your team. Right. Yes. Now, what precautions, Garima? What incision you want to take for this patient? The abdominal incision and then the uterine incision. Yes, go ahead.
Nowadays we can take transfers, but preferred is the vertical incision.
Yeah.
Preferred, but we can proceed according to expertise by transfers also.
Right.
On abdomen.
But a big one. So
Big.
that you can explore
Adequate
everything.
space. Yes, we can get the adequate space.
Yes.
And about uterine incision, as the placenta is covering the whole of the uterine segment, so we have not to cut the placenta. We will have to spare it. So we will take upper transfers, or we can go for vertical classical type of cesarean section.
Yes. So classical or transpondal, that is called as transverse fundal. Right. So if you take vertical, make sure that you don't reach or incise the placenta. Okay. So you take a vertical incision, you deliver the baby, and absolutely no attempt to cut the separate the placenta. Right. And then you immediately go ahead with the obstetric hysterectomy. Right. But suppose this patient insists, now that you have stopped her bleeding, and suppose this patient insists on uterine conservation, then how do you go ahead?
And that interventional radiologist can help here.
Okay. If you don't have interventional radiologists, there are so many people, no, surgeons also expert in internal iliac ligations and bilateral uterine artery ligations. Anything is what is called as triple P procedure. You have two conservative procedures. Anybody from the panel want to say? So there is a procedure called as triple P procedures, 3 Ps. So first is mapping of the placenta that you do on MRI. Okay, you map the placenta, even the depth of the placental invasion. So you map the placenta, and if it is a patchy adherence, then definitely you have to second what is called as patchy resection. Okay, placental mapping, then you have stepwise pelvic devascularization. That is the second P. And third is patchy resection. You resect the myometrium along with the placental segment, and then you suture it. So this is what is the triple P procedure. And then of course, recently what is called as Comog MG stitch. MG is Mahesh Gupta. So he has devised one procedure where he takes a bilateral uterine artery ligation. He does how we do routine pelvic devascularization, but at the lower uterine segment where you take the incision, he does what is called as high uterine ligation, both the sides. And then doing complete devascularization, he just takes a scalpel and scrapes out the uterine cavity. Okay, and then he packs it for a while. So this is how we have seen also the procedure. It is absolutely bloodless. The patient doesn't bleed. It is called as Comog MG stitch. Okay, stitch that you at the angle, both angles of the incision, you take through and through, anterior to posterior, the whole thing you tie it. Okay, so the uterus becomes absolutely avascular for that period, and definitely you can scrape out the placenta. That is how
Could you
it is.
please repeat the name of the procedure?
Comog, that's a stitch. Comog MG. MG
Okay.
is Mahesh Gupta. If you put just search on Google Comog MG. Okay. I have many videos also. I can share with you. Okay.
Yes,
So
ma'am. Thank you.
so two conservative procedure, triple P and Comog MG. Okay. So basically for this patient, as what is important is now in this catastrophe, you try to resuscitate her, try to supplement her whatever blood and blood components you can. If at all by the time she stops bleeding and gets stabilized, and then you get time, then you can go ahead with this conservative procedure. But if at all the patient worsen, it's the maternal life first. You have to get rid of this bleeding, and you have to stop the bleeding source, definitely. So you have to go ahead with the hysterectomy as soon as possible. So if it is so that you are just wasting minutes and minutes, the patient may lose life rather than losing her uterus. So you have to take a call that if the patient is stable, then only think of the conservative procedures. If the patient is unstable, there's absolutely no question. You don't have any alternative for going ahead with conservative procedures. So these are the special precautions we have already discussed. Now the million-dollar question: was it preventable? Meera, I'm sure you will answer everything so that we conclude this panel. Was it preventable when you diagnose the placenta as low-lying? Whether you could have gone for prophylactic os tightening? Was there any role of tocolytics? Very stupid questions, I'm saying. Okay. So,
Ma'am, no question is stupid. They are very good questions actually. Was it preventable? Yes, it was preventable. If we had an early scan, even an NT scan, at that time it is very easy to diagnose morbidly adherent placenta on NT scan, because the whole lower segment is full of placenta at that time. And plus we see very low resistance, very high brilliant vessels going across the myometrium. So it is not difficult. And especially when you
I
have
think if I just add that even the low-lying gestational sac, even during the first trimester scan, anteriorly, when you have the previous Caesar, and if you have a low-lying gestational sac anteriorly, that also can just give you an indication where you can keep a watch on this. Right.
Yes,
Now,
ma'am.
what about os
And
tightening?
os tightening, no role of prophylactic os tightening. And if you go for a Shirodkar, especially in such cases, there is a chance that it will bleed, because when we dissect the bladder off, you will find those big vessels, and then the bleeding will become uncontrollable.
So absolutely no for os tightening, because a prophylactic os tightening per se has no place unless it's a short cervix, and for that you want to do, right? Role of tocolysis.
Role of tocolysis in only when there is established preterm labor, no role of prophylactic tocolysis. And obviously, if there is preterm labor and if the patient is having contractions, then we have to give tocolysis.
Right. So we have lots of cases, but I think just last this case I purposefully want to discuss. We will not take the whole case as such, but only I will read it out that we had this grand multipara, who came to emergency ward at 11 p.m. She was a case of obstructed labor with tachycardia, blood pressure normal. The mother was exhausted and there was a thick meconium stained liquor. So with antibiotic cover and fluid resuscitation, she was taken for cesarean section, and the 4 kilo distressed baby was delivered. There was a slight extension, but repaired well. There was no hematoma, absolutely no bleeding intraoperatively. She was fine. After shifting to ward, almost an hour later, she looked anxious, restless, and her blood pressure was 80 millimeter of mercury, pulse 3D, drowsy, and vomiting tendency. So there was absolutely no bleeding outside. The abdomen was soft. Uterus was well contracted. What do you feel the diagnosis is? And any panelist, I would say, because this is the last case. I would just ask you, what is this case? She's in shock. Absolutely no bleeding.
Amniotic fluid embolism or septic or anaphylactic shock.
Septic within half an hour, 1 hour.
Pulmonary embolism.
Pulmonary embolism more
or
likely.
peripartum cardiomyopathy.
Okay.
Peripartum cardiomyopathy.
Okay. So all these are the causes of non-hemorrhagic shock, right? So our patient did have non-hemorrhagic shock. So suppose now you feel that yes, she's got, because she's in shock, you give her aggressive fluid resuscitation, BP not coming, you give her vasopressors. Even though you feel that there is no bleeding, because she's in shock, you keep, blood and blood components ready. But any bedside investigation you want to do at this point of time?
If she's stable.
Ma'am, if there is a facility to get.
Okay, I will give you fast diagnosis.
ABG, ECG.
Okay, her bedside hemoglobin is 10.8, so bleeding is out.
Serum D-dimer level.
We see her blood sugar very high, urine sugar 3+, her ketones 2+. What is it? Sugar 3+. Diabetic ketoacidosis.
Non-diabetic ketoacidosis.
No,
Non-diabetic ketoacidosis.
no. She's diabetic ketoacidosis. Sugar's very high. Non-diabetic, undiagnosed diabetic, I would say.
Sometimes it is because of fluid DNS and all these things.
Yeah, but her sugars are very high. Blood sugar is high, urine sugar is 3+, and urine. That is how you have to see what are the causes of non-hemorrhagic shock. Okay, so simple tests like the urine sugar, blood sugar, bedside sugar. Okay, so the management, of course, because we have lack of time, I'm just going through, we are trying to avoid everything. We know, all of you know, and with your physician friend, you are going to manage this patient, because you have to give aggressive fluid resuscitation and you have to give insulin as per your physician friend. But could this have been prevented? What was the simple investigation that was missed?
Okay, sure. Sneha,
yes.
Excuse me because I'll have to log in for Gurukul, okay?
Yes, madam.
Yeah.
That's what.
And thank you very much. I think excellent panel. The selection of the cases, real learning, okay? And in placenta accreta, you almost covered everything.
Yeah.
So early diagnosis, treat every case of previous section with anterior placenta as adherent placenta.
Yeah.
Operate in a tertiary care center. Keep the blood bank backup has to be there, multidisciplinary team. And we are coming up with a pass registry in ICOG.
Yeah.
I will be just announcing it, and once I get a ethical clearance, we'll start. So we will share the web link. Those who are managing placenta accreta cases, please enter your cases there so that we will be able to see what is happening in India. So that is the another initiative from ICOG. Okay, thank you.
Thank you, madam. Thank you. So this was a simple case where she was not at all screened for GDM, and suddenly she landed up into diabetic ketoacidosis because she was into obstructed labor, dehydration. So you have to just take precaution and, make sure that you screen every woman during every pregnancy, right? Every woman during every pregnancy. Not that first pregnancy I did not have diabetes, so now you will not have. No, nothing. So every pregnancy, every woman during every pregnancy should be screened routinely at the first point of antenatal contact, that is first antenatal visit, and second at 24 to 28 weeks of pregnancy. And yes, if she comes late, even at that point of time, again 4 weeks later. So that is how we have to make sure that she's not a case of GDM, because if she is diagnosed as GDM, you can definitely manage her on MNT in 90% of the cases, that is the diet modification and active physical exercise. If not, then only you have to add some medication, maybe metformin, maybe insulin, though insulin is the first drug of choice. So with this, we conclude the panel. It's not only the obstetric SDU and ICU, but every team member of the obstetric unit should be well trained and well versed with the basic life supports, right? And we should never refer the patient in the bad condition, because if at all the mishap happens in this situation, that is the worst thing, that is criminal. So with this, I thank all of you, wonderful panelists, very well read, and wonderful discussion. Thank you so much.
Thank
So
you,
disclaimer,
ma'am.
not contesting
Yes.
any election, it is simple academic contribution. Okay, thank you so
Thank you,
much.
ma'am.
Yes,
Thank
over
you,
to you,
ma'am.
Pranjal.
Thank you,
Yes.
Pranjal ma'am.
Thank you. Such a nice panel. So very nice panel. So nice cases, madam. Thank you for so many inputs. At the end of this scholastic and sagacious webinar, on behalf of ICOG, I extend my sincere gratitude to everyone who contributed to the smooth conduct and success of today's webinar. My heartfelt thanks to my dear and respected ICOG chairperson, Dr. Sheila Mane madam, our convener, Dr. Sneha madam, for the warm welcome, invocation, and efficiently anchoring several important segments throughout the webinar. My sincere thanks to both speaker, Dr. Seema Dande and Dr. Bhakti Gurjar, for enriching on hyperglycemia and HDP. Our expert, Dr. Manjula madam, whose experience and insights enriched the program. We extend our gratitude to all dignitaries who graced the occasion and shared their guidance and encouragement. Our sincere appreciation goes to Darshan, who has conducted this program so well. Thank you so much.
I can
And
see Dr.
again,
I'm so sorry to interrupt you, Pranjal. I can see Dr. Sangeeta, but we did ask for expert.
Dr.
Sangeeta, are you there around? Dr. Sangeeta? No, I think she's not active. Okay. So we thank
So, to
she's the
conclude,
expert.
sincere appreciation goes to all chairpersons for their scholarly roles. And once again, thank you, Buyar madam.
Thank you. Thank you, Vedehi and Pranjal, for all the coordination, and thank you, everybody. Thank you so much.
Thank you so much. Thank you so much.
Thank you.
Chalo, bye-bye. Bye. Garima.
Yes, ma'am. Thank you so much.
Pleasure to have all of you.
Ma'am, I have learned that several new things, especially that Gupta stitch and about triple P therapy. We are not aware of that stitch.
Oh.
So,
He had been to my programs quite often, and because see, I was an obstetric emergency committee chairperson, no, here also this side, AMOX. So every new emergency, I have almost more than 200 programs, no. So I had invited him for PPH many times, and surgical management of PPH. So that is how you save mothers.
Thank
And
you,
we
madam.
enjoy doing that.
thank you
Yes,
so much, ma'am.
Manoj, Meera,
Thank you, madam. Thank you very much.
Shweta, thank you.
Always great learning with you, ma'am. Thank you.
Thank you so much. Thank you, dear. Thank you. Bye-bye.
Bye, ma'am.
Bye.